Hello, everyone. Thank you for joining us for the 2021 Los Angeles NET Patient Education Virtual Conference presented by LACNETS. This year's conference theme is Connected in Hope, Facing NET Together, which we will be going over more in depth later in the program. I'm Lindsay Judovine, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen. I'm the Program Director for LACNETS.
Before we get started, we have a list of people to thank today. Thank you to Rich at TVP Live, the tech genius behind all of this. We'd also like to extend a special thank you to all the presenters, patients, and caregivers who are participating today. We'd also like to thank our sponsors who made today possible. Thank you to our presenting sponsors, Ipsen and AAA. Thank you to our silver sponsors, Novartis and Tercera. And thank you to our bronze sponsor, Intrinsic Bioscience. I'd like to remind all participants of the opportunity to speak with and virtually visit the 5 participating pharmaceutical companies today. Each has their own virtual sponsor booth found on the LACNETS conference page, www.lacnets.org/2021. This year, the first 100 participants to visit and confirm their visit of each virtual sponsor page will receive a $10 Starbucks gift card sent to them via email. To confirm your visit, on each of the 5 sponsor pages, scroll down to the bottom of each dedicated sponsor page to find the Confirm Your Visit form. This is where you'll type in your name and email address to confirm your visit. Be sure to do this on all 5 sponsor pages to receive your gift card. Also, if you're not following LACNETS yet on social media, be sure to give us a follow to stay up to date on upcoming events, net news, and announcements. You can find us on Facebook, Twitter, and Instagram with the handle @LACNETS. Now, before I pass it off to Lisa to kick off today's conference, I'd like to remind our viewers that our virtual conference and webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. Now, I'll pass it off to Lisa to go over a brief history of LACNETS and our programs and introduce today's group of moderators.
LACNETS is a program by Generate Possibility, a registered nonprofit. LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society, and our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer since we understand NET is a type of cancer and not cancer-like or benign as previously thought. LACNETS was initially founded in 2012 by jazz musician and composer Giovanna Joyce Mbesi, who lived richly and fully with metastatic neuroendocrine cancer for 14 years until succumbing to her disease in November 2019. After she was diagnosed with NET, she pursued an MBA for the sole intent and purpose of launching a NET patient advocacy group in Los Angeles. I had the privilege of caring for Giovanna during her final days, during which she said, with great pride, that she felt her greatest legacy was founding and building LACNETS. Giovanna was especially proud of NET Vitals, a tool she and I created along with Dr. Dan Lee from City of Hope to empower patients and improve the communication between physicians and patients. Giovanna's hope was to help as many people as possible learn to thrive while living with neuroendocrine cancer. And we, the LACNETS team, are deeply committed to carrying on her torch. It's important to note that LACNETS is in fact led by a team. So while you often see Lindsay and I leading the meetings and programs, we are in fact led by Kavya Velakapudi, board member Donna Gavin, who's also the sister of LACNETS founder and executive director emeritus Giovanna Joyce Mbesi, and our board also includes Mary Dunleavy, who has been living and thriving with NET for 16 years. LACNETS is not just a team. We are also a NET community, a collaborative community of NET experts, those living with neuroendocrine cancer, meaning patients, and family friends who support NET patients, meaning caregivers. We collaborate with local and national NET centers and organizations. We aim to build and strengthen connections among those in the NET community because we know we are stronger together. And that is why this year's theme is Connected in Hope, Facing NET Together. Despite the challenges of distance and the pandemic, and even with our diversity in gender, race, and identity, we are all connected by the hope we share. We understand that living with neuroendocrine cancer can be really hard, and we've been facing extraordinary circumstances over the past year and a half. We acknowledge the common struggle with feelings of uncertainty and powerlessness. So we hope today's conference will not only be educational, but also empowering and inspiring. Today, you will hear a lot of information. It might feel overwhelming, but rest assured that this is being recorded and can be watched again on our LACNETS YouTube channel. We also have many programs, including our weekly support groups for NET patients and caregivers, a dedicated caregiver-only support group, NET Connect, which is our peer buddy mentorship program, health coaching, NET Vitals, NET Retreats, and more. You can find out more on our website, lacnets.org. I want to take a moment to say a few words about getting connected with a support group. NET support groups or patient advocacy groups are a really valuable source of education, networking, and support. Some of you may be a bit like me. I first came to LACNETS just for the educational programs. I was that person who would sneak in quietly and hide in the back of the room just to listen to the presentation. I didn't come when my husband was first diagnosed with NET and instead waited almost a year because I imagined a support group was a place where people held hands and sat in a circle singing Kumbaya. Nothing wrong with that, but I just thought a support group wasn't for me. When I did finally check out LACNETS, I wish I had come sooner because I was really blown away by the quality of the educational content, by how well informed the participants were, and most of all, by the sense of hope that came as a result of the education, empowerment, and networking. I came for the latest information on NET treatments, but I stayed for the community. It's even easier now in the virtual world to hide and just view the educational programs on a screen. And it's also easier to join a support group since many support groups are meeting virtually and you don't have to worry about things like driving time, traffic, or finding the nearest bathroom. There are many support groups out there locally and nationally that are available for you to connect with. And if you need help getting connected, feel free to reach out to us and we can help. I'm very excited to share a new resource we have to offer. You may or may not know that I'm from an immigrant family myself. English was not my first language. My father was a foreign medical grad, and I grew up watching my parents struggle with barriers due to language. We at LACNETS care about diversity, equity, and inclusion, and we want to help improve access to NET education, advocacy, and support. We are thrilled that several of the speakers were kind enough to also offer their presentations in Spanish. We must give Dr. Duma the credit since this was her brilliant suggestion. These may be for you in your own heart language, or you may want to share them with family or friends so they can better understand what you're going through and better support you. To this end, we have launched our Spanish resources page, which includes 3 of the NET expert presentations and 2 patient caregiver stories from today's conference, as well as other bonus materials. Check it out on our website, lacnets.org/Spanish resources. Just a disclaimer that the LACNETS team is not proficient in Spanish, so unfortunately we're not able to converse in or respond to emails in Spanish. Our live Q&A today will be in English only. Just a reminder that the live Q&A with all the experts will take place at the end of the day. You can submit your non-case specific questions at slido.com. Enter the event code LACNETS 2021. Now I'd like to introduce some very special people. This is our first annual conference that was designed from the very beginning as a virtual conference. Being 100% virtual gave us the opportunity to do things differently. This year, instead of inviting mostly local experts to our local institution to talk mainly to Southern Californians, LACNETS invited speakers from across the country to join us in our own homes, in our own living rooms. Joining me today as co-hosts and co-moderators of today's conference are 4 very important people in our LACNETS team. 2 NET experts who often host many of our in-person meetings and conferences, and 2 people living with NET who are part of our NET Connect peer mentorship team. They will be sharing their thoughts and perspectives about the topics we are going to discuss today. I'd like to invite them into our studio now. I'm thrilled to welcome our co-moderators for our 2021 Los Angeles Neuroendocrine Tumor Patient Education Virtual Conference. They are key figures in the LACNETS community who serve and care deeply about our NET community. So I'd first like to invite each of you to introduce yourself. who you are, where you're from, and your role in the NET community. Let's start with you first, Dr. Hendafar.
Thank you, Lisa. My name is Andrew Hendafar. I'm a medical oncologist working at Cedars-Sinai Medical Center in Los Angeles. I'm a medical oncologist who specializes in the treatment of neuroendocrine tumors.
Thank you, Dr. Hendafar. Welcome. And let's go to you, Dr. Lee.
Hi, everyone. I'm Dan Lee. I'm a GI medical oncologist at City of Hope and co-direct the neuroendocrine tumor program here at City of Hope.
Welcome, Dr. Lee. It's good to have you. Let's go to you, Mary.
Hi, my name is Mary Donlevy, and I live in Southern California. And I have been a pancreatic neuroendocrine patient and lived a very full and active life despite my diagnosis 16 years ago.
Welcome, Mary. It's great to have you. And last but not least, Beth.
Hi, my name is Beth Wilbanks DeBlaze, and I'm a GI NET, and I was diagnosed in 2016, going on 5 years, living very fully as well with NETs.
Thank you so much for being here. And in this first section, we're going to first talk about the first part of the NET journey. So oftentimes, when someone first finds out that they have NET, you would often see a medical oncologist or perhaps a surgeon. You'll often hear that advice, go see a NET expert. So I'd love to hear from each of you, what advice do you have for a NET patient who's preparing for their first consultation with a NET expert? Let's first go to you, Dr. Hendafar.
That's a great question. I think it's really important that one keeps an open mind when they're going to see a NET specialist. You might have a preconceived notion of what the recommendation might be or what the plan of care is going to be recommended. But I think it's best if you keep an open mind, try to listen to what the physician is saying, and I think you'll be pleasantly happy with what you hear.
So I think I'm biased somewhat in this. I've been working with LACNETS for a long time, and I would say my recommendation to you is really to go on the LACNETS website and immediately fill out your NET vitals. So this is really a communication tool that I've been able to develop alongside with LACNETS, and it's essentially a checklist to allow you to find out what you don't know about your NET diagnosis as well as treatment, and ultimately what questions you can ask your physicians as well as providers to get the necessary information throughout your neuroendocrine tumor journey.
Yeah, on the heels of what Dr. Lee said with NET Vitals, one of the biggest recommendations I can possibly give is to make sure you have 2 complete sets of records, and one of which is sent ahead to your physician and then one you bring into the office so everybody is well prepared prior to your appointment. And really important also is to make a list of questions that you have for your physician. It'll kind of keep you on track, and you often may not get the amount of time you want with your doctor. So it'd be really helpful to have the list of questions prepared prior, and any questions that come up in between appointments from here on out, I would highly recommend you write those down as soon as you think of them so you don't forget anything. You think you won't, but I promise you will. So that'll help you in preparation, and it will be really helpful for the doctors as well.
Following along the same lines of advice, one thing I would recommend is that it's okay to experience a little overwhelm during this first initial visit. And because of that feeling, it's probably a good idea to go in with also something like a pad and pen, not only with your NET vitals, but even if you have access to any kind of recording device that you're able to refer to later. Because trust me, you'll probably need to refer to it later, and that will be something that will be vital to you and your physician as you go through this process.
Thank you, Dr. Hendafar, Dr. Lee, Mary, and Beth for sharing your advice and insights about this topic. And now we're excited to introduce our first set of speakers. I'll hand it off to you, Mary.
I'm very pleased to introduce you to Federico. He is a pancreatic NET, and similar to myself, had a Whipple a number of years ago. And he has lived a very, very fulfilling life post-diagnosis. And I think you'll find his story very inspiring.
I'm very pleased to present a good friend and colleague, Dr. Heloisa Soares, who is a medical oncologist from the Huntsman Cancer Institute of Utah. She's going to give a presentation titled, What to Expect with the NET Expert Consultation. And a fun fact is that she trained at UCLA, where she earned her MD and a PhD in molecular biology. So welcome her home today.
And I am honored to introduce Dr. Calicia Clark, who is a surgical oncologist from the Medical College of Wisconsin. And her presentation is titled To Cut or Not to Cut, What Your NET Surgeon Wants You to Know. And I think that's a very relevant and important topic for our NET patients.
Thank you all. And for our Spanish-speaking audience, Dr. Suarez's presentation and Federico's story is available to view in Spanish on our website. And the URL is lacnets.org/Spanish resources. Thank you to our presenting sponsor, Ipsen and AAA.
Hi, my name is Federico Kalinek. I am 69 years old and I have pancreatic NET stage 4. I was diagnosed with PNET in 2012, 1 week before Christmas. The CT scan showed a huge tumor in the pancreas and multiple metastases in the spleen, stomach, duodenum, jejunum, and liver. The KI score was higher than 30, indicating it was highly aggressive. My prognosis was not good. No possibilities of treatment or surgery, and 2 or 3 months top of life. The physician's recommendation was go home, make your arrangements, and try to enjoy every day. In spite of this dark scenario and with the support of my family and friends, I was very lucky to find a surgeon that accepted the challenge. And on January 23, I underwent an extensive Whipple procedure. In a 12 hours intervention, my pancreas, spleen, the bottom of my stomach with the pyloric valve, the duodenum and the jejunum were completely removed. A portion of the left jugular vein in my neck was used to repair the porta system in my liver, and several metastases removed from the liver itself. After 10 days, I went home walking, but my oncologist told me I was not in conditions to receive any treatment, and I should wait and look for the evolution of the tumors. I was feeling better and better, and except for the diabetes caused by the removal of my pancreas and minor digestive problems, my life was quite back to normal. After 1 month, I returned to work, and without any specific treatment, the CT scan showed no changes in the liver metastases for up to 30 months, 2.5 years after the Whipple. In August 2015, however, new and bigger metastases were found, and the next month I had a second surgery to remove the right lobe of my liver and clean up as much as possible the rest of the organ. After this surgery, in October 2015, I started the treatment with the somatostatin analog lanreotide. Other than surgery, this was my first medical treatment, and it still continues. For the next 5 years, my condition was stable. I continued working, traveling, and enjoying life. In July 2020, last year, however, more and bigger metastases were evident in my liver, and my oncologist prescribed a lutetium-177 PRRT treatment. I started this treatment in October 2020, and the last injection was just last month. I had no problems or side effects, and I hope everything will be fine. At all, I consider myself a very lucky person. The original estimation of 2-3 months of life became 100 months and counting. I was able to see my grandson to grow, my sons to organize their lives, and enjoy many moments with my wife and friends. I was able to work and travel inside and outside the US, and I am now organizing my retirement, making plans for more trips to know more places together with my wife. I look back and realize that I've learned to appreciate more than before life, family, and friendship. And that I live this last year more intensely than many of the previous ones, when my only goal was looking for success at work. Looking forward, I see more and more treatments for PNET being developed. Lanreotide, for example, was approved for PNET by the FDA in December 2014, and it was available to me when I needed it in 2015. Lutathera, the lutetium-177 PRRT treatment, was approved in 2018 and was available to me when I needed it in 2020. I hope an even better treatment will be available soon, giving me the opportunity to enjoy life for many more years.
Hello, everybody. Thank you so much for being here. First of all, I would like to thank the organizers, the LACNETS, for inviting me to join you today to discuss a little bit and learn a little bit about neuroendocrine tumors and neuroendocrine tumor neoplasms. As you saw, this is my title. If I was giving an academic talk, these will be my disclosures. That means that these are the companies that I had received some small honorarium if I gave opinions about their studies or their drugs, and they're listed here for full disclosure. So, I was asked to tell you what should you expect from meeting with a neuroendocrine tumor expert. First of all, I should say that you're going to learn that you're not alone. And why? Because we are seeing that the incidence and prevalence of neuroendocrine tumors are really going up in the last several years. Incidence is the number of new patients that have been diagnosed with this disease in the year. And prevalence is the number of patients that they're living with this disease on a given time. And you can see here that when you look at the different types of cancers, they are fairly stable. But when you look at the incidence of neuroendocrine tumors, you see this exponential increase. Some of this is probably because we're doing a much better job in diagnosing this disease. Also, when you look at prevalence, you can see that it's a quite common tumor. We used to think that they're very rare tumors, but actually, as the incidence increase and the patients thankfully live for most of the time for a very long time, the prevalence increases as well. And it's just behind colorectal, lung, ovarian, then you see neuroendocrine tumors as a whole. And you are not alone. You should know that in the United States now, there is about an estimative that there are more than 170,000 patients living with neuroendocrine tumors. The second thing that I think you should take it from seeing a neuroendocrine tumor expert is that neuroendocrine tumors can take a long time to diagnose. And many times the patients have been misdiagnosed. How many times have someone heard that they had IBS and then later on, fast forward 5-7 years, they actually all this diarrhea and constipation and abdominal pain end up not being IBS, and then rather you have a neuroendocrine tumor, unfortunately, particularly in the small bowel. Initially, when the tumor is just in one location, you might not have a lot of symptoms. But as the disease progresses and it spreads, then you can start developing my symptoms, particularly when you have metastatic disease. That's when we see potentially a lot of the quote-unquote carcinoid syndrome symptoms that patients talk about, including flushing and diarrhea. And you can see here in this is a classic graph that shows that it can take sometimes more than 8 years to get the diagnosis. Also, you should expect that the neuroendocrine tumor expert is very familiar with symptoms. This was a survey that was published a few years ago and led by several institutions that are part of the International Neuroendocrine Cancer Alliance, and they show that all these symptoms are described by patients. It's probably very familiar to you. The issue with fatigue, muscle fatigue, weakness, the diarrhea, the cramping with abdominal pain, this skin reactions such as flushing, rash, wheezing, headaches, nausea, anxiety, palpitations, change in the blood pressures. You see, my blood pressure is now going high all the time, and I can't explain heartburn, the weight loss, issues with memory fogginess and confusion sometimes, issues with increasing the fat content in the stools that can be called, it's called steatorrhea, problems with visions and things like that. And probably you're feeling, wow, I had many of these problems. So when you see a neuroendocrine tumor expert, they're going to be very familiar with that, and they're not going to necessarily ignore such symptoms. The third, even after diagnosis, is very complex and complicated, and I'm walking you through the slide. The first thing that you need to know, and the neuroendocrine tumor expert is going to focus on, are we talking about when we look under the microscope at the cells, at the cancer cells? Are we talking about a well-differentiated cancer or tumor, or a poorly differentiated tumor? So what is that? Is how the cells look similar to normal cells. And the poorly differentiated tumors are cells that tend to be dividing much faster and more aggressively, and they look very disorganized. Whether, on the other hand, the well-differentiated tumors, when you look under the microscope, they tend to be a little bit more similar to normal cells, and they have a little bit more order on them. And this is extremely important because the natural history of a well-differentiated tumor is very different from the natural history of a poorly differentiated tumor. And also the treatment options are extremely different, right? If you have a well-differentiated tumor, chances are when you need systemic treatment, you're going to start with a hormone injection, octreotide or loriotide. Whether if you have a poorly differentiated tumor that's a much more aggressive tumor, chances are that your first treatment is going to be with systemic traditional quote-unquote chemotherapy. So that the first thing, your NET expert is going to really pay attention to that and is going to explain the difference to you. Second, you have to pay attention on the grade. Are the tumors and the pathologists in the pathology report are telling this is a grade 1, grade 2, or grade 3? And there has been a recent change in the classification by the WHO organization that added a third option. We think that before we used to say any grade 3 tumor, and I'll explain a little bit how you define grade 3, they by definition are poorly differentiated. With time, you learn that that's not the case, that there are many tumors that can be well differentiated and yet can be a grade 3. So how do we call grade 1, grade 2, and grade 3? We look at the differentiation, the well differentiated versus the poorly differentiated, and then we look at the mitotic rate and the Ki-67 index. Most of the time we focus more on the Ki-67. Ki-67 is an index of proliferation under the microscope, or how fast the cells are dividing. So the pathologist is going to be the sample of a biopsy, is going to stain with a dye, if I may, that is specific to count the proliferation index of the cells. And then if the pathology counts the Ki-67 less than 3, we call it a grade 1. That tends to be, at least in the context of the cell, the ones that are extremely slow growing and dividing very slowly. If a tumor has a Ki-67 between 3 to 20%, this is going to be a grade 2 tumor, which is in between very fast dividing cells and slow cells. And then if the Ki-67 is more than 20, then this is going to be a grade 3. And then in the grade 3, we have to go back and say, is this a well-differentiated tumor or this is a poorly differentiated tumor? Typically, the well-differentiated tumors that are grade 3, the Ki-67 tends to be from 21 to 40 or so, but it's not impossible to see these tumors with a Ki-67 up to 60-something% or even higher than that. And then the ones that are poorly differentiated typically have a Ki-67 that tends to be above 80. In particular, if something like a small cell subtype of the poorly differentiated tumors are seen. Small cells are unfortunately the most aggressive subtype of neuroendocrine neoplasms that we have. And because of all the different new names, we now, when we think about all the neuroendocrine tumor world, we call them neuroendocrine tumor neoplasms. And we subdivide neuroendocrine tumor if the Ki-67 is in the lower end with a well-differentiated morphology, and we call it neuroendocrine carcinoma if these tumors have a poorly differentiated morphology. And that's important, again, because sometimes we get pathologists from outside and the pathologists say neuroendocrine carcinoma with a Ki-67 of 2%. And then I look at that and I say, I don't think the pathologist that read this is up to date with the most recently WHO 2018 recommendations, and hence probably we should do a pathology review. Also, this is important because insurance companies will focus on that to give or deny treatment. So I have many times that I had to addendum the pathology report after the review to justify giving a treatment to a patient. Then the other aspect that neuroendocrine tumor expert is going to focus in, where's the tumor coming from? And we normally think in the embryonic origin of the tumors, and we divide it particularly related to the chest and the belly in foregut, midgut, or hindgut. And for example, a tumor in the small bowel, we say that's a midgut tumor. Whether a tumor that started in the lung or the stomach or pancreas, we call it more in the foregut. And then this might have impact on the treatment options for you. For example, we know the patients that have a pancreatic neuroendocrine tumor may respond extremely well in the metastatic setting when the disease has spread to a combination of 2 chemotherapy pills called capecitabine and temozolomide. On the other hand, we really don't have a lot of good evidence that if a patient has midgut tumor, meaning starting the small bowel, that they will respond to the same chemotherapy. So that's important to understand where the tumor is coming from, so you can decide what's a good treatment option for you. And then the fourth thing that the NET expert is going to talk to you and assess is whether your tumor is functional versus non-functional. And what does that mean? Whether or not your tumor is secreting hormones and peptides that will cause symptoms such as the flushing, the diarrhea. If someone has a tumor in the pancreas that is secreting insulin, your blood sugars will go low. So this is all related to secreting these peptides and hormones that will potentially lead to symptoms. So you should ask your physician, do I have a functional tumor or I have a no-functional tumor? And patients that say that they suffer from carcinoid syndrome, which is again the classic aspects are flushing and diarrhea, sometimes bronchospasms. They are the ones that are functional. And most likely, if a patient has a functional tumor in the midgut that corresponds to carcinoid syndrome, they will have high levels of serotonin, which we should measure, not by measuring the serotonin in the blood, because that is very non-specific and can vary through the day a lot. But there is the 5-HIA, that's a substrate that can be measured either in the urine, by that 24 hours urine that your doctor might have asked you to do, or in few centers we can actually do in the blood as well. Here at Huntsman, we can check in the blood. So my joke with patients that I don't have to torture them collecting 24 hours urine. But if someone is suspected to have a tumor in the pancreas that is secreting insulin or gastrin, they will check for that particular hormones in the blood as well. So the fourth thing that you should expect from a neuroendocrine tumor expert is to actually, again, pay attention of your pathology. And this was a study that was presented on the European Neuroendocrine Tumor Society meeting, which is a big meeting, and had documented that when pathology reports have been reviewed at a center of excellence for a particular disease, there's a lot of change in the diagnosis. And that's important, again, because if you change your diagnosis, we might change the treatment options for you and potentially can impact on your survival. So as a matter of fact, in this study, they showed that in up to 50% of the cases, once the pathology review for a second look or a pathology that is specialized in neuroendocrine tumors, there was a big change in the diagnosis, and that led to a clinical impact in the management of these patients in up to 30% of the cases. So you should expect that a good neuroendocrine physician expert is going to ask for a pathology to be reviewed. And also, that goes along with probably presenting your case in a multidisciplinary tumor board, where we have all different specialties, including the medical oncologists, including the pathologists, including the radiologists, the gastroenterologist, the surgeon, the nuclear medicine physician, and potentially a nutritionist that's going to be on that. Sometimes genetics or a genetic counselor is involved. And discussing our case on tumor board setting has also shown in a study that was again presented in the European Neuroendocrine Tumor Society meeting, showed to impact the care of these patients in the way that they, up to 50% of the time here, for example, they added new imaging and also change the treatment for the patients is up to 56%. And again, I as a physician, I like to show data. So this is a way to really show to you the impact of seeing a neuroendocrine tumor expert. Then fifth, so this is just to show you how overwhelming this can be. And I pick up the NCCN guidelines, which is something that the physicians in the US use a lot to guide treatments, particularly if they are not necessarily focused on the disease. All right, physicians that are in the community, they take care of tons of different cancers, and it's hard to keep up with every single cancer. So many times they refer to the NCCN guidelines to look for guidance. And then I pick up pancreatic neuroendocrine tumors that are well differentiated. And then you can see here, you have your diagnosis, you order your imaging, and then, if the tumor can be resected, should be resected. If the tumor is asymptomatic, perhaps you just monitor without starting treatment. Or the tumor is symptomatic, you start treatment. And then after your first treatment, you can see here, all these options. I can count, let's say, 1, 2, 3, 4, 5, 6, 7, 8 options listed. Oh my God, how do you know which option is the best one for you? So someone that is familiar with neuroendocrine tumors and is going to take a look at your scans and understand the natural history of your disease, understand how much disease you have, how many symptoms you have, and all these important aspects of making an informed decision, the neuroendocrine tumor expert is going to guide you and help you to decide. There's very little, if none, data comparing all these treatments head to head. So that's why it's so important to consult with someone that does this for a living, that had the sense of what's probably the best option for you in terms of sequencing the treatments. There's a chance that thankfully you will be able to get all these treatments through a very long period of time. And the key is to try to understand what's the best treatment for you at a particular time. To go along with this, as I hope I have been showing to you, neoplasms or neuroendocrine tumors are very complex, and you need any extra help that you can get. So an ed expert can help you decide if surgery is an option for you and what type of the surgery is the best one for you. For example, if you have a tumor in the tail of the pancreas, do you need to have all your pancreas or half of your pancreas being removed, or perhaps you can just do enucleation, meaning scoop out that tumor? Someone that does this for a living will be able to assess that quite well. Another thing, if your tumor is super small, does the tumor really needs to come out? There's a lot of data that suggests that pancreatic neuroendocrine tumors that are less than 1 centimeter in size and are well differentiated, slow growing, perhaps we can just monitor. But is that the right option for you? Many things have to be taken into account. What about the tumors that are between 1 to 2 centimeters, where the zone of, there's so much more gray zone to decide whether or not this tumor should come out? So that's one way that meeting with an expert can be important. Again, the other thing that can happen is deciding what's the best time to start systemic treatment for your case. And not two cases are the same. For example, if someone has a very slow growing tumor that maybe has only a few spots here and there in the liver, and that's it, and this tumor has a very low Ki-67, it might be perfectly okay, especially if the patient has no symptoms, to just monitor and repeat scans in 4 to 6 months. On the other hand, if someone has a lot of symptoms, have a lot of disease, or a Ki-67 that shows that the tumor is a little bit more aggressive, might be not a good idea to wait to start treatment. So an ed expert can really decide what's the best timing to start treatment. And also deciding when it's time to change treatments, because that's one thing that we see a lot. Patients get their scans and then the radiologists say, oh, some tumor progression. But then if you open the scans and look yourself, or a net expert looks by themselves, they'll see, wow, this was a growth of 3 millimeters in the last year. Do I really need to change treatment? No, especially if the patient is feeling okay. So understanding and assessing your case to decide when it's time to change treatments is something that a net expert can also do. And deciding which sequencing makes sense for you. Oh, for this particular time, depending on how my cancer is presenting and the amount of disease, should I do liver embolization? Should I do chemotherapy? Should I do PRT? And things like that. And also another thing that I think is super important to include a neuroendocrine tumor expert is deciding what's the best imaging modality for you and how frequent should you have scans. Sometimes I see patients getting a single phase CT scan, and they get scans, I don't know, every 3 months or so. The problem with doing a simple phase on the CT scan is that you might miss a lot of these tumors because you need the multi-phase, or you need an extra timing of the contrast, which is called the arterial phase, to be able to capture all these tumors. There are many papers that have been shown that if you don't do the right scan, you might miss a lot of the disease. Also, if someone has a fatty liver, which is hepatic steatosis, CT scans might miss some of the disease, and MRIs might be more appropriate. MRIs tends to be more specific and sensitive, but they are also more labor intense to do it, right? You can be 30 minutes in the machine. So not necessarily every single person needs MRI, but there are particular circumstances that MRI might be better. So that's when the net expert can discuss with the radiologist and decide what's the best approach. Also, some patients only need scans once a year. Some patients need scans every 4 months. Very rarely, for a well-differentiated slow growth tumor, we need scans every 3 months. Perhaps that's too much, and that's another thing that the net expert can help you with. And also designing, helping to strategies to deal with your symptoms. Neuroendocrine experts are very familiar that diarrhea doesn't mean all the time that this is related to the tumor per se. Surgery can cause diarrhea. The use of the hormonal shots, the somatostatin analogs can cause diarrhea, and a few other things can happen. So this assumption that every single patient that has diarrhea and has a neuroendocrine tumor has the diarrhea because has a carcinoid syndrome is wrong. There are many other possibilities for that, and a neuroendocrine tumor expert physician is going to pay attention and decide it on whether your symptoms are related to the cancer per se or not, and help on the strategies to address that. Also, you should expect your net experts to coordinate your care with your local oncology, right? Pick up the phone, send the notes, talk to the nurse. All these things should come naturally because we don't have a net expert in every single city in the country. So most of the net experts are very used to coordinating care with local docs. And also can potentially, when the time comes, can potentially identify clinical trials that might be good for you. And this is what I wanted to show you here is that if you go to clinicaltrials.gov, which is a well-known internet search website to find trials, and if you type neuroendocrine tumors, this is how much pops up initially. And I got the map with all that. We don't have 145 trials with neuroendocrine tumors in Texas. This is just, so a net expert can help you to really identify which are the trials are relevant for you. And then if the net expert doesn't have the trial on her or his place, can even discuss with you about would you be able to, travel to this or that destination to do that. And I feel like it's our job as net docs to help to facilitate and help to educate the patients on which trials are good for them or not. So the seventh reason why I think seeing a neuroendocrine tumor expert is important is to eliminate confusion. You go to your first appointment with someone that perhaps is not familiar with NETs, and they get all confused with the terminologies. They call a neuroendocrine tumor, and they tell you that's a benign tumor. But you say, how is it benign if I have lesion that had spread to my liver? Or they call it carcinoid, and you say, well, carcinoid is a terminology to the past. So it can be super confusing, right? So a NET expert can sit down with you, go over all this, and avoid confusion for you and for your local healthcare provider. I think the eighth reason to incorporate an NET expert on your care is to help with trust issues. We know the medical mistrust is associated with poor cancer's clinical compliance, reduced adherence to treatments, and decreased quality of life, which potentially can impact survival of the patients. And because of everything that the NET patients with neuroendocrine tumors have the experience, particularly because sometimes it takes so long to finally get an answer for the symptoms, there's a lot of trust issues, which if you see a neuroendocrine tumor expert, you will see, oh my God, this person talks my language, this person understands what I have been going through. And so you feel much more comfortable seeking the advice and following with a treatment plan. And this was a post that was presented by Dr. Moen and Dr. Coombs when she was at Stanford that showed this issue. And they also then, Dr. Mo was her fellow at the time, and then they wrote this paper together, which I think Josh Mayman also helped to put together to really show to everybody what patients really go through. One patient, for example, said mentioned that the frustrations, like when you have to educate every physician that you meet, you realize that you know more of your disease than they do. It makes it difficult to build trust and confidence in the medical community. I'm sure many of you have experienced that. You talk to your local doc and they say, oh, I haven't seen many of these tumors, I don't know what you expect. So that's another reason to seek the support of a neuroendocrine tumor expert. Just to touch bases on few myths, there are several myths in terms of seeking second opinions and searching for the right team for you. Number one, there's a myth that your doctor will be upset if you seek a second opinion. That's not true. The doctor should want the best for you, and they should be happy if you go for a second opinion. If they don't, maybe they're not the good doctor for you. Myself, I offer to my doctors, for my patients all the time, if they want to see a second opinion. And here are some phrases that if you're afraid of bringing that up, how you can phrase it to your doctor about that. The second myth is that could be expensive. So as far as I know, Medicare actually, for example, covers a second opinion visit. So it probably is less expensive than you think it will be. Obviously, if you have to travel to a different state, that can be costly. But now we should leverage the idea of telehealth and use that as an opportunity to do second opinions between patients and centers that allow for that. The third myth is that it's too difficult, can take time, there's a lot of paperwork. Not really. Sometimes you just have to do one online form and the schedulers will call you and they take it from there. And the fourth myth is my health condition isn't life-threatening, so I shouldn't bother. Well, I disagree, right? You're here for the long run and you really should take advantage of the time that you have, that you don't have to rush it, and build a good team for you. Just be careful with if you decided to go for your seventh opinion. I think 2 to 3 opinions are very important, but at some point, if you start going for 10 opinions and dragging decisions for too long, that might be not in your best interest. So, and don't forget the role of kindness. And I think you should find a team that is kind. And then, in general, not because of cancer, but in general, life is too short. And we really should find a team that you are comfortable with. Just as a guidance, this was written by a physician. The kindness in the cancer care that you should look for is deep listening, empathy, generous acts, addressing your concerns in a timely manner, being gentle, and paying attention to supporting family and caregivers. And I think most of the neuroendocrine tumor experts in the country have all these qualities, and you should take advantage of that. So my take-home message is that, you know, if you don't live in an area that has a neuroendocrine tumor expert, find a primary oncologist that you trust, and it doesn't have to be a NET expert. If your primary oncologist is not in a NET center or a NET specialist or friendly to NETs, you know, seek your second opinion, do your homework, be your own advocate. We know that goes a long way. Use reliable sources of information. LACNETS has a wonderful collection of information for patients, the same way that the NordCal has, the same way that the HealingNet Foundation or the Carcinoid Foundation or the NET Research Foundation has, and many other supportive groups. So educate yourself using these very reliable sources of information in addition to your team. And supportive groups are amazing. But please obtain through medical advice from people that is not aware of your case might be very dangerous. Not two cases are the same. Each patient is a little bit different. And so I think you can share your experience, but when you get to take medical advice, really take from an endocrine tumor expert or from a medical team. And that's what I have for now. Thank you and gracias.
Thank you, LACNETS, for the opportunity to talk a little bit about my favorite topic, which is neuroendocrine tumors. Really privileged to be here today. So I think it's really essential for us to talk a little bit about the surgical implications for patients that are diagnosed with neuroendocrine tumors. And I thought it would be just a good idea to walk through some of the tips that I talk with my patients about when they come into the office to see me for the first time. So I always start off with a little bit about neuroendocrine tumors because it really is important for us to understand how rare this disease is and why it's so critical for us to seek out expertise. So there are only about 12,000 new neuroendocrine tumor patients diagnosed in each year in the United States. And so that represents far less than 1% of all cancers diagnosed in the United States. What that means is it's a very rare disease, and the person that's often giving you the news or making the call that you do have a cancer may not have ever seen this disease or ever treated this disease. Because it's so rare, it's oftentimes associated with a delay in diagnosis. We always describe neuroendocrine tumors as zebras because they're relatively uncommon. And most people think of horses, whereas neuroendocrines are usually really not thought about when people see masses or when patients present with symptoms. Again, because it's so rare, your initial practitioner may be unfamiliar with how it's treated. And so the number one piece of advice that I give patients is you really need to be treated at a high volume center, because the expertise and understanding what your cancer is and how it behaves is really important to making sure that you have the very best outcome. Additionally, neuroendocrine tumors are, by definition, a multidisciplinary disease. It's very rare that the single person that you see is going to be able to provide all the care that's necessary to treat or cure your neuroendocrine tumor. And so you have to be at a center where a team of experts are available to help you with your disease. The good news is that even though there are only about 12,000 diagnoses per year, there are over 175,000 people living with neuroendocrine tumors at this very time. And so that means that a lot of our new diagnoses patients will be alive for a long time. And even if we can't get to a cure, we can often extend life and extend the quality of life for all of our patients. Another reason that it's really important for us to understand NETs and why there's a delay in diagnosis is because these can be very silent killers. Most neuroendocrine tumors are non-functional, so they don't secrete hormones, or if they do, it only happens in very late or advanced stage disease. So these cancers can be asymptomatic or associated with vague symptoms that get missed and get undertreated for a really long time before the neuroendocrine tumor diagnosis is actually made. And because of that, patients will often have disease spread either to the lymph nodes or to the other organs in the body about 50% of the times or even more. And explaining to patients that that in of itself is not a death sentence is really critical. And so I have up a little bit of information about how that relates to your overall survival. So for example, a patient with a pancreatic neuroendocrine tumor is likely to be alive at 5 years if their disease is only in the pancreas about 93% of the times. The likelihood of being alive at disease decreases if there's a disease in the lymph nodes or if it's spread outside of the lymph nodes and into perhaps the liver. Similarly, for gastric or GI neuroendocrine tumors, the 5-year survival rate is much higher in patients that have disease only within the bowel. But even with distant spread, we have relatively good survival at 5 years, which is 67%. And so one of the other things that I tell my patients is that they can't really look online for their specific disease until they understand what they have. And this is a conversation I have quite commonly in patients that especially have like pancreatic neuroendocrine tumors, where they may Google pancreas cancer, and the data and the information regarding that is vastly different and much more dismal than patients that come in with a pancreatic neuroendocrine tumor diagnosis. So I get to give a lot of hope and often good news, even within a diagnosis of advanced cancer for the patients that come into my clinic. Another question I get from my patients is, how will my neuroendocrine tumor behave? Am I going to be one of those patients that's going to be alive at 5 years, even after surgical resection? And so I always have a preliminary conversation about how we can somewhat predict how tumors are going to behave. So tumor grade is really important, and understanding what tumor grade is and how it relates to your diagnosis is really important. Low-grade tumors or grade 1 tumors have cells that are dividing at a relatively low rate, and they're sort of termed slow growing. Oftentimes, patients will come in with low-grade tumors that have probably been there for years and years, if not decades. And those tumors, even when there is distant spread, can still be very adequately treated with surgery and with medical management. Higher grade tumors, like intermediate grade tumors, and high grade tumors, which are grades 2 and 3, have cells that are dividing a little bit more rapidly. And so these can be more challenging to treat. When you see a low-grade tumor, that's always a harbinger of good biology. And I think it gives us a little bit of reassurance about being very aggressive about surgical resection and medical management, with the hopes of getting us to extended life and a good quality of life. The other thing that every patient needs to know about is their tumor differentiation. Well-differentiated cells basically look more like normal cells, whereas poorly differentiated cells are very atypical. And poorly differentiated cells are much more aggressive and much more likely to fail surgical intervention. And so in that case, we really try to leave surgery for either a later stage or even not at all, because these tumors tend to respond better to medical management or systemic treatments. Understanding the combination of both of those things is really important. So a well-differentiated tumor that's grade 1 will, in general, have a much more indolent course. And so surgery and multiple surgeries may actually be implemented to increase survival, decrease symptoms, and increase quality of life. How will I know if surgery will benefit me? This is a really common question. And I tell patients, again, it depends on your tumor. We just talked about the importance of grade. We also talked about the importance of tumor differentiation. But the other part that's also critical is the stage of disease and the volume of disease. And one of the most important things for me as a surgeon is trying to figure out how much disease is present and where is the disease present. Even in the setting of distant metastasis, we can often achieve either a cure or a significant debulking of the tumor disease, depending on where the tumor is located. This does sometimes often require multivisceral resections, which means that we're operating on multiple organs in a body, and the complexity of the surgery will be a little bit higher. But for a lot of patients, especially young and healthy patients, this can be tolerated quite well with minimal morbidity in the hands of somebody that does these operations very frequently. The other point that I think every patient should know is that none of the decisions about surgery or medical management should be made in isolation. A single physician should never manage your neuroendocrine tumor. Really requires a team approach. So a surgeon, medical oncologist, interventional radiologist, other radiologists, and so many other people will be a part of the team that manages this disease. And I always think that a surgeon, especially at the time of diagnosis, is really critical, because trying to decide how much liver volume is too much or how much liver volume is safe for resection should probably come from a surgeon as well. I see a handful of patients every year that were never evaluated by a surgeon, that have very treatable and possibly curable disease, who just have not been referred to a surgeon. And so surgery was never part of their treatment algorithm. And we've been able to convert those patients to surgery and improve not just quality of life, but certainly length of life in the right hands. The other thing that I talk to patients about is the fact that neuroendocrine tumors can be anywhere in the body. They're most frequently located in the small intestine. About 55% of neuroendocrine tumors are going to be what we call GI carcinoids. About 20% of neuroendocrine tumors are going to be located in the pancreas primarily. And then about 20 to 25% are going to be tumors that are centered or began in the lung or bronchus. What that means is that the surgical expertise that you need is going to be highly specific to your tumor. So there are some surgeons that will do small intestine surgery, but not pancreas surgery. And so you need to understand where your tumor is so that you can get the very best person that's capable to do your operation. I happen to do cancers of the abdomen. So I do liver resections, pancreas resections, small bowel resections, colon resections, but I'm not a chest surgeon. So if I see a patient with a lung neuroendocrine tumor, even though I absolutely enjoy treating those patients, if they need a surgery in the chest, I'm not the best individual for them. I think this is particularly important for patients that need liver resections and pancreas surgeons. Those two organs especially require additional expertise in the foregut. And again, an expert should be sought for those two lesions. The overall goals of my neuroendocrine surgery every time are to do the same things. I want to remove the tumor. I also want to get some healthy tissue right around it to ensure that we've gotten as many of the cancer cells as possible. We call that resection with a negative margin. We want to minimize debility, alleviate symptoms, and offer a cure whenever possible. For localized neuroendocrine tumors, which are tumors that are only in existence in the place that they started, surgery alone is often a very effective treatment. And so these patients will typically have surgery, and then we survey them for a possibility of recurrence. But typically in well-differentiated low-grade tumors that are localized, no additional therapies are needed after surgery. In the setting of regional or distant disease, which means that's disease that's spread to the lymph nodes or to the other organs like the liver, while surgery is still a mainstay in low-grade, well-differentiated neuroendocrine tumors, some additional medical therapies are often required after surgery to either lower the risk of recurrence and also to extend life or to lower the symptoms from your neuroendocrine tumor. Even whenever we cannot completely remove a tumor, sometimes a debulking surgery is recommended. And this is specifically effective in patients that have tumors that secrete functional hormones or that have carcinoid symptoms. So in a debulking surgery, what we try to do is remove as much of the tumor as possible. Our goal is to get to 80% or more to try to decrease the risk of symptoms and minimize the hormone production for patients that have neuroendocrine tumors. And while the goal here is not a cure, it still does often extend life and improve symptoms for patients. In some patients, the tumor may be rather large at the time of presentation or in a really tricky location. And sometimes we have to use what we call a neoadjuvant approach, which is where we give a systemic treatment or a medication up front to try to decrease the size of the tumor or cause it to pull away from critical structures, or just to simply make sure that we have good control of the disease before we do a big operation. And it makes the surgery much safer and much more feasible in a lot of those cases. And lastly, while your surgeon is really critical for your surgical resection of your neuroendocrine tumor, other members of the team, especially your anesthesiology team, also are really critical. in my patients with metastatic disease who have had carcinoid syndrome. The surgery itself and the general anesthetic does put you at risk of developing carcinoid crisis. And so an anesthesiologist who is aware of this problem and knows how to mitigate it is pretty critical. Briefly, just to talk about a few of the adjuncts to surgery, these are additional therapies that we will use to maximize the effects of surgery and minimize the risk of disease coming back. Again, this widely varies depending on your tumor grade, and its location. So somatostatin analogs, chemotherapy, targeted therapies like everolimus, immunotherapy drugs, and of course, peptide receptor radionuclide therapy can all be employed in addition to surgery to try to maximize overall survival for patients and to decrease any symptoms from our neuroendocrine tumors. Summarizing, NETs are rare. And because they're so rare, you need to see someone who treats this disease often to ensure that you have the very best outcome that's possible. Teamwork makes the dream work. It really does require multidisciplinary collaboration and multidisciplinary communication to ensure that the patient is always at the center of all of our goals. Surgeons are critical members of your team, and you want to like your surgeon because you're going to have a lifelong relationship. I absolutely enjoy seeing my long-term survivors for neuroendocrine tumors whenever they come into my clinic. It really reminds us of why we went into this, and we get to catch up socially on all the things that they've done since my first surgery. So hopefully that helps. And again, thank you so much for the opportunity to talk to you guys today.
Thank you, Federico, for sharing your story of courage and hope. And thank you to Dr. Suarez and Dr. Clark for your excellent presentations. In this next section, we're going to talk more about treatments. So I'd love to hear from each of you. What is one thing you would share with a NET patient who's starting to think about treatment options, whether this is after surgery or at a time when there's progression? Dr. Hednefar, let's start with you.
I would recommend that the patients consider going through each option and imagining what their future will be like on that specific treatment option and how that might play a role into the decision making.
My advice to a patient is that there are so many different treatment options that are available for patients with neuroendocrine tumors, and that no one neuroendocrine tumor patient is really the same, and everyone is completely different. So when you're getting various different types of opinions, you're going to have a lot of different choices. And the most important advice I would say is that you really have to have an open dialogue with your entire medical team to decide ultimately what's the right decision for you, because at the end of the day, you're the most important person in this journey.
So I would say, as I stated, I have been a NET patient for 16 years. And if there's one thing I've learned, it is there's rarely one way to proceed with treatment, like Dr. Lee just said. One of the best ways I would suggest to get some feedback is to have your case reviewed by the tumor board at the multidisciplinary tumor board at your institution, so that you can have a number of NET specialists weighing in on your treatment options, which will help you give you confidence in your future decisions.
Along the same lines as my fellow moderators, knowing that NETs is a marathon, you're going in with that mindset that you, along with your team, is making a customizable management system for you, and what's going to give you the best quality of life that fits your path on this journey.
Thank you, all of you, for your insights. So we're now excited to share the next set of speakers. Take it away, Dr. Hednefar.
Okay, I'm very happy to introduce Dr. Halfdannerson, Professor of Oncology from Mayo Clinic. His talk is titled, When to Walk, Sprint, or Stand on the Sidelines, Surveillance, Maintenance, More Treatments.
And I'm very happy to welcome our radiology colleagues. So first up is going to be Dr. Tom Hope, who is a radiologist as well as nuclear medicine physician from UCSF, and has really led the way in terms of introduction of PRRT in the United States. So his talk is going to be on radiation safety with PRRT. In addition, I would also like to introduce Dr. Charles Nutting, who's an interventional radiologist from Endovascular Consultants of Colorado. And he's going to be really discussing the role of liver-directed therapy with the title of Liver-Directed Therapy for Neuroendocrine Tumors.
Hello, my name is Thor Haft-Anderson. I am a medical oncologist and the professor of oncology at Mayo Clinic in Rochester, Minnesota. And I would like to thank the organizers for inviting me to speak at the meeting. And I will be talking about when to walk, sprint, or stand on the sidelines, essentially surveillance, maintenance, and more treatments for neuroendocrine tumors. These are my disclosures. So I wanted to address a few questions, and these are the questions I was hoping we could address. So can we predict the behavior of neuroendocrine neoplasms? And can we especially predict how aggressive we need to be in regards to therapy and in regards to testing? And do we always need to treat? And if we don't treat, how should we follow patients who are not on therapy? We'll talk about the goals of the treatment, as well as the role of maintenance therapy. So let's start by talking about predicting the behavior of neuroendocrine neoplasms. And notice that I mentioned neuroendocrine neoplasms, or NENs, not NETs. That's because neuroendocrine neoplasms is a big term that encompasses both well-differentiated neuroendocrine tumors as well as poorly differentiated neuroendocrine carcinoma. And why do we need to know this at the diagnosis? So that's because knowledge is power, and we need to really know our enemy. So neuroendocrine neoplasms are a very heterogeneous group of cancers. So they behave in a variety of ways, and they can start really anywhere in the body. They can be extremely aggressive, they can be very slow growing, and they can be anywhere in between. And being able to predict the future behavior of neuroendocrine neoplasms is very important and can help with difficult treatment decisions, can help with deciding on when to sit on the sidelines or when to sprint. So we need to know the tumor grade and the differentiation. So let's talk a little bit about how we do that. So the NETs or NENs can, as I said, be among the slowest growing tumors in humans as well as the fastest growing tumors. And this is largely determined by the tumor grade and the differentiation. And I was hoping I could explain the difference between those two terms. So grade 1 tumors tend to be very slow. They move slowly. Grade 3 tumors tend to move fast. But these are not absolute terms. There can be grade 3 tumors that don't move all that fast. So how do we decide on a tumor grade? How do we assign a tumor grade? And we do that with a system using a tissue stain called Ki-67. So essentially what we do is that we stain a tumor sample and we see how many of the cells stain positive. Essentially, how many cells does the stain stick to? And the more cells it sticks to, the more cells are actually actively growing and dividing, and the more aggressive the tumor will be. And that will help us predict how it will respond to therapy sometimes and how it will do over time. And if we're going to the grade 3 tumors, which is the highest grade, so this goes from grade 1, grade 2, and grade 3. But the problem is that grade 3 tumors, which are increasingly being recognized, are not all the same. And it's tricky sometimes to predict the behavior of grade 3 neuroendocrine tumors because they can be fairly slow growing if they're well differentiated neuroendocrine tumors, or they can be really fast growing too. So that becomes a little bit of a challenge. And this really requires an expert pathologist. That's why we would always ask our pathologist to take a look at the actual tissue sample when we see a new patient. So what is tumor differentiation, and why is that not the same as tumor grade? Well, the tumor differentiation is really how much the cancer resembles the cells, the normal cells it originated from. So does it look quiet and well-behaved, and then we call it well-differentiated tumor, or does it look aggressive, and then we call it poorly differentiated tumor? So the poorly differentiated tumors are much more aggressive, and on the left-hand side, we can see sort of a sloth-like, well-behaving, low-grade tumor. and a more aggressive tumor on the right side. So the grade 3 tumors are really the most challenging ones because they are all high grade, but some of them are fairly slow growing, and all poorly differentiated tumors are high grade or grade 3, but not all high grade tumors are poorly differentiated. So grade and differentiation is not the same, but it is not just about grade and differentiation. We need to consider some other factors too, especially when we decide on whether to start a person on therapy. So we need to know how much tumor there is. Is there a lot of tumor? Are there other organs in danger because of tumor extent? And are there symptoms, especially symptoms of bulky tumors causing pain or pressure in other organs, or symptoms of hormone production? So moving on to the goals of therapy. So when I talk about goals of therapy, we have to be mindful of the fact that sometimes the goals of therapy that the providers have, may be different from the goals of therapy than the patient has. So we need to make sure that we're all on the same page. So, and that brings me to the next question. Why do we even treat patients with neuroendocrine tumors? What are the sort of overarching goals of doing that? And the way I look at it is really twofold. So number one is to relieve symptoms. Someone comes in suffering from symptoms. We need to do something to help with that. So these could be symptoms of the carcinoid syndrome, symptoms from bulky tumors, or symptoms from functional pancreatic tumors causing hormones that can make a person sick. And we also treat to prolong the survival of patients, essentially to allow a person to live longer. And just be mindful that not all treatments, drug treatments or other treatments, have been conclusively shown to prolong survival. And we also have to be mindful of treatment toxicities. So all treatments have side effects, and it can be easy to harm a person with therapy. And that doesn't have to be just physical harm, but also can be financial harm. These treatments can be very expensive. So let's go into a case, and this is a real world case story. This is one of my patients saw a few years ago. 72-year-old man, retired, very active, overall pretty healthy, some minor health issues like high blood pressure. Came in to a local emergency room with abdominal pain, recent onset, severe pain. He had a CT scan that showed a kidney stone, so we found the cause of the pain. The kidney stone passed, the pain went away, but there were several liver lesions. And as you can see on the right-hand side, there's a liver, that big gray thing there, and there are some little darker spots in the liver there. These are small liver metastases. And this is a dotatate PET. And here is a small bowel tumor. This is the primary tumor sitting in the small bowel, and there were some liver metastases as well. So we concluded that the pain was not from the small bowel tumor, and we did the liver biopsy that showed a grade 1 neuroendocrine tumor. So we sat down, we talked about the findings, we talked about the fact that this was an incidental finding, this was not a tumor causing the pain. So at the end of the day, he said, well, I don't think there's urgency in starting therapy. Let's just wait. And so we did, and we waited several years, and then he moved out of the area. And unfortunately, I don't know how things are going right now, but we went several years without doing anything and watched these tumors grow very, very slowly. And when we last met, they were still pretty small. So not everyone is comfortable with waiting. So you have to really explain to patients that sometimes it's actually okay to wait. And one size does definitely not fit all. So we need to balance the risk of waiting with the risks of starting therapy, as all treatments have side effects, as we talked about. And there may be issues with cost and access to therapy. And then some people just don't want therapy for a variety of reasons, and we have to be respectful of that. So that brings us to the question to treat or not to treat. So I say you treat when you really need to treat. And the fact that we can treat does not always mean that we should treat. So we can do a lot of things, but we'll do those things when we really have to. But these are some rules of thumb. So if you have a poorly differentiated neuroendocrine carcinoma, those tend to be very aggressive, and they typically require urgent therapy. But sometimes persons may be elderly, frail, and they may not want treatment directed against the tumor, and some people just want to be kept as comfortable as possible. So you need to probe these questions, and then you really need to establish the goals and the patient's wishes. And then patients with extensive neuroendocrine tumor and with high tumor burden, they should probably be offered therapy as well, because they can have symptoms from compressive tumors or hormone production. So when is it then okay to wait with treating patients with advanced metastatic disease? So it seems kind of odd that we suggest sometimes waiting when someone has a biopsy-proven advanced malignancy. So grade 1s and some grade 2s we can observe if there is a low tumor burden. Then the question is, how low is low? So the person I showed you had small liver metastases, mostly less than 1 or 2 centimeters. So that was not a whole lot of tumor. There can't be any concerning symptoms, such as troublesome symptoms of carcinoid syndrome like diarrhea and flushing, and no mechanical problems, bowel obstruction, or tumors pushing on other organs. There has to be good access to follow-up care, especially if things happen. We need to be able to bring people in quickly to take a look. And then obviously this is a shared decision making. We have to talk to the patient and explain all of the options as objectively as we can. So this is reflected in the current National Comprehensive Cancer Center guidelines. So these are the guidelines that many oncologists use in practice. And this is taken from the page that talks about treatment of patients with advanced or metastatic disease. And as you can see highlighted here, asymptomatic or absence of symptoms, low tumor burden, we can actually observe with imaging. We don't have to treat. This is clearly in the guidelines, as you can see. But if there are symptoms, obviously we have to go after those. So, and people would say, well, wait, is this really supported by data? Can we really do this? How do we know it's safe to wait? And we actually do have some data. So there was a study called the Clarinet trial, patients with relatively low-grade neuroendocrine tumors that were advanced, and 200 some patients, they were randomized either to placebo or a drug called lanreotide, which you may recognize. And then the patients who got the placebo, they went for an average of 18 months without tumor progression. So as you can see, they did pretty well. The tumors ended up growing in more of the placebo group patients than the others, and eventually they had to be switched. But in terms of overall survival, meaning the life expectancy, there was really no difference. And so that is, I think, a fairly strong argument for us being able to wait in select patients. So let me show you another real-world case story. This is actually a fairly recent case. So a 68-year-old woman who had the small bowel neuron tumor resected 12 years ago. And then over the last few years, slowly worsening diarrhea and flushing, and then more recently shortness of breath and the lower extremity swelling. Some weight loss, and she was starting to feel some fullness in her abdomen. So she was found to have a very large liver tumor and on echocardiogram severe carcinoid heart disease and very high plasma 5-HIAA. So as you can see there, this tumor lights up very bright. So this was really a solitary liver metastasis which was making a lot of serotonin, causing a lot of problems, and also just causing weight loss and the discomfort. So we did the liver biopsy. This was a grade 1 neuroendocrine tumor. So should we treat this person? Well, the person, the first case also had the grade 1 neuroendocrine tumor. Can't we just wait here as well? And in this person, no, we actually can't. There are notable differences here. So this is a large tumor. It's causing a lot of symptoms, and she has complications of her tumor, including carcinoid syndrome and carcinoid heart disease. So what we ended up doing was a bland liver embolization just to stop this from making serotonin. She felt a whole lot better, and now we're getting prepared for valve surgery and eventually liver surgery. I actually saw another patient this week who was in this same situation 3 years ago and is now without evidence of disease after having had heart surgery and liver surgery. So sometimes I call this the art of doing nothing, but doing nothing is really not doing nothing, because waiting and watching someone carefully is really not doing nothing. We're actually just not using drug therapy or other therapy. We're monitoring people closely. So doing nothing is really not a correct description, but I just like the art of doing nothing. So we're waiting. So now what? So the surveillance depends on the situation. So tumor grade, extent, symptoms, and all of the things I talked about before, and the comfort level of the patient and the family, and then available resources like access to care and things like that. If something were to happen, can you get in quickly and have it looked at? So when in doubt, this is my rule, when in doubt, see patients more often. You don't have to scan every time. So clinic visits every 2 to 4 months. If you're in doubt, maybe every 2 months. And if things are stable over time, we can sometimes extend this and even up to 6 or even 12 months. There are people who are not on therapy in my clinic I see once a year. And the most important tools is just to sit down with the person, either in person in the clinic or on the screen, because now we do a lot of that. And then you can do imaging studies. Imaging studies are really important, but more important is to actually talk to the patients and examine them. Tumor markers, at least right now, have a limited value in this. So let's talk briefly about what to do after surgery, because that's another situation where we like to do nothing or just wait. So adjuvant therapy, so drug therapy after surgery, has no proven value, so we typically don't do that after resecting or removing well-differentiated neuron tumors. But there may be some benefit of doing that in more aggressive tumors. So we scan, and at regular intervals, we meet with people, we do blood work, and typically 3 to 6 months after surgery, and then 6 to 12 months after surgery, up to 10 or even 15 years after surgery, because we want to make sure that we catch the tumors early enough if they come back. So let's briefly wrap up by talking about the essentials of neuron tumor therapy. And here I actually will talk about what we do for well-differentiated neuron tumors, and I will not go into the details of poorly differentiated neuron carcinoma, because that's a totally different disease. So how long to treat, with what, and when to change the treatment. So the duration of treatment, once you're on therapy for advanced or metastatic neuroendocrine tumors, you're typically on treatment for long term. So once on therapy, most people stay on therapy. There are some exceptions to that, of course. So most patients start with somatostatin analog therapy, either octreotide or lanreotide, and they continue that often throughout their illness indefinitely, especially if they have syndrome or like a carcinoid syndrome or a functional tumor that produces hormones. Then we typically like to have people stay on this treatment. So what are then the reasons for changing the treatment? Well, number one, the treatment is not effective. There is no reason to continue with treatment that's not effective. And then we move on to what we call the next line of therapy. But often, for some, at least for some people, we continue the somatostatin analog therapy. The options really depend on the type of the tumor. For small bowel neuroendocrine tumors, we have limited options. So it would be PRRT or lutetium-177, also known as Lutathera, everolimus, and then clinical trials, and some other drugs we rarely use, such as interferon. For pancreas, we actually have more options, and we'll get into that a little bit more here. So another reason to stop or change the treatment is if the treatment is not well tolerated. If there's a lot of toxicity, really troublesome side effects, we really have to change the treatment. And then some patients, unfortunately, cannot afford a certain therapy, and that may force us to move to a different therapy that maybe has a more favorable coverage. And then we have other treatments such as telotristat, which are not necessarily treating the tumor, but more treating the symptoms. And then, of course, there are always the patients who just want to stop the treatment. And then we have to talk about, is that really safe because of the symptoms? And sometimes people just want to take a little break, get some normalcy back where they're not constantly coming in for treatment or taking a medication. So this is really my final slide, and I just wanted to quickly walk you through the differences in small bowel and pancreatic NET therapy, because these are the most common tumors we deal with. So for small bowel neuroendocrine tumors, we tend to start with a somatostatin analog therapy, such as octreotide or lanreotide, and when that is no longer working, we go to either PRRT or everolimus. We sit down, we talk about these options, and then jointly make a decision what to do next. At any point, if there is, let's say, progression within the liver or liver-only disease that we can treat with surgery or embolization, as one of the other speakers or some of the other speakers will talk about, we will do that. This all just really relates to drug therapy that I'm talking about right now. So we can address those things. Let's say if there's 1 or 2 liver metastases that are growing, we can certainly do something about that. But in terms of drug therapy, we have the PRRT and the everolimus or Afinitor, and possibly a kinase inhibitor after that. There's a drug on the horizon called surufatinib that is looking somewhat promising and hopefully will be studied in the US, and we can always look at clinical trials. So this is pretty much what we do for small bowel neuroendocrine tumors. For pancreatic neuroendocrine tumors, we have some other options. It makes sense to start with somatostatin analog therapy, But then once progression is noted on that, we have a number of other options: PRRT, everolimus, sunitinib, and chemotherapy with capecitabine and temozolomide, also known as CAPTEM. We sometimes even choose to start with chemotherapy, let's say if there's a lot of tumor and a lot of symptoms from the tumor, and we really want to see shrinkage early on. And then we sort of cycle through the options there. Well, we pick one, and if that doesn't work, we go to another one. And sometimes other factors play into this, including like other diseases that patients may have. Let's say if someone has really bad high blood pressure, we might want to stay away from sunitinib as that worsens the blood pressure. If someone has really bad diabetes, you want to stay away from Afinitor or everolimus because that can worsen diabetes. So there are more things that we have to factor into this than just the tumor itself. So once we've cycled through all of these options, we can look at other things like clinical trials. And that's actually what I wanted to bring up here, because at any given time, if your physician tells you, well, things are not really working as I hoped, you should ask about clinical trials, because thankfully there is a lot more clinical trial activity going on now than it was 10, 15 years ago. So this brings me to the end of my presentation, but I really look forward to taking questions from you. Thank you very much.
Good afternoon. My name is Thomas Hope. I'm a radiologist and nuclear medicine physician at the University of California, San Francisco. And I was excited to give them the opportunity to speak here at the LACNETS conference for the first time. And I'm going to speak today about radiation safety and how it relates to PRT, or peptide receptor radionuclide therapy. I think radiation safety is a really important topic, and I think there's a lot of misunderstanding, particularly amongst the patient community, about what are the real risks and how to minimize that when it comes to treatments with PRRT. So let's get going. The first thing I want to start off with is talking a little bit about the difference between external beam radiation therapy and PRRT. We don't use a lot of external beam radiation therapy in neuroendocrine tumors, but it is a very common modality that is used in a lot of cancers. And with external beam radiation therapy, radiation is aimed sort of through the patient. You have a beam where we aim at a specific tumor and irradiate that tumor for a period of time, usually something like 10 to 20 seconds, a very short, high dose rate beam. And the toxicity from external beam radiation therapy is, in essence, directly related to where that beam is aimed. And there's no toxicity beyond the region where the radiation is aimed. And when the beam is turned off and the patient leaves the facility, there is no exposure to anyone else around them. So it's very easy to determine what toxicities are going to be from external beam. Now, that's very different from peptide receptor radionuclide therapy, right? In PRRT, we're taking a small molecule, in this case dotatate, a somatostatin analog. We're attaching radiation to it. In the case of PRT, that will be lutetium-177, and we inject that into a patient's body. That lutetium dotatate then circulates throughout the body, and its biodistribution in the body is what is going to determine the toxicity of the patient. And that radiation is deposited over many weeks. The half-life of lutetium is like 7 days, and so it's not just a short period of time, it goes over a long period of time. And then that radiation is emitted outside of the patient, can expose people nearby. So with external beam, after the treatment, patients emit no radiation, so there's no risk to exposure to others. Whereas with PRRT, after the treatment, the patients do emit radiation, and depending on the radionuclide, and for the example of lutetium-177, this can impact patients nearby or family members nearby. So let's take a quick comment about units. I think this is something that, in all honesty, confuses me, and I need to look up these units all the time because they're a little bit confusing. There are units like millicurie or megabecquerel or gigabecquerel. These, in essence, refer to decays per second. So, for example, 1 becquerel is a single decay in 1 second. Okay, so if I'm injecting an activity of 1 becquerel, that is going to have 1 decay per second. Now, you can convert becquerels to megabecquerels, right? Thousands, millions, to gigabecquerels. And millicuries, or a curie, millicurie I think is 37,000 or 37 million becquerels. And honestly, the exact conversions are confusing and you just have to look it up every time. But the idea is it's just an amount of decays. It has no measure of the amount of radioactivity emitted. Now, those decays will give off radioactivity. And that radioactivity will interact with tissue or material nearby. It can be a radiator, it can be wood, or it can be a person, their human tissue. And that is measured in units called gray, or rads. Now there's two of these because, just like feet and meters, we have different types of units, metric versus non-metric units. So we have gray and rads as well. Now, the gray, or the rads, the energy that's deposited, can have a different effect on different tissues. And we take into account tissue-specific sensitivities to radiation to create units like rem, or millisieverts. And this measures the actual effect on the tissue. So for example, kidneys are very resistant to radiation. So you have a lot of dose that goes to the kidneys, but there's not a lot of toxicity in the kidneys. Whereas the bone marrow, for example, it's a very low dose with PRRT. But because it has a very high sensitivity, it has a much higher effect. So the millisieverts is taking into account tissue-specific sensitivity to the energy that's deposited into it. So we go from the left here, which is millicuries or megabecquerels, and that's units of decay. That decay gives off radiation that has a certain amount of energy. We measure that energy in gray or rads, and then that energy interacts with human tissue, and we measure the effect on that tissue with rem, or millisieverts. Now let's take a step back and talk for a second about lutetium-177. So with PRRT, we are labeling a somatostatin analog, or dotatate, with lutetium-177. This is a radiometal, and it decays by giving off radioactivity. Now the half-life of lutetium-177 is just under 7 days. So that means every week the amount of radioactivity left over goes down by half. Now the most important form of decay of lutetium-177 is an electron, a beta particle. We call it beta decay. This electron travels about 1 millimeter in soft tissue. About 90% of the radioactivity emitted from lutetium is in the form of a beta particle. And this beta particle is what kills the tumor and also causes patient-specific toxicity. So bone marrow injury, kidney injury, things like that is what's caused by this beta particle. And as you can see, there's different energies of beta particles that are emitted, and that's probably not important. The important thing is that this beta particle it doesn't leave the patient. In essence, because it only travels 1 millimeter or so, it's fully contained within the patient. Now, lutetium also decays by giving off gamma particles, or photons. This gamma decay, which is about 17% of the decay of lutetium, and I know those don't add up to 100, but that's because sometimes when you have a decay with an electron, it will also give off a gamma particle, so don't worry too much about that. Gamma particles, or photons, are very different from electrons. Instead of only traveling 1 millimeter, they will exit the patient and interact with tissue or materials around the room. Okay, we can image this and measure that radioactivity, and it's what causes exposure to family members and people around the patient. Okay, so remember, 2 types of decay with lutetium-177. One type is beta particles, or the electron. That's causing the injury to tissue and causing treatment of the tumors. The other side is photons, or gamma particles. This we can use for imaging. It's not used for therapy and can deposit dose into patients or family members surrounding the patient. Now, if we think about somatostatin receptor targeted risks, right, of PRRT, we can have risks such as patient risks, kidneys and bone marrow, right? So the radioactivity, these electrons will interact with the kidney tissue and the bone marrow tissue and cause injury to that tissue. We can also have injury to family members around them. That gamma radioactivity can be emitted outside of the patient, right? Interact with patients, but also, more importantly maybe, is the urine. A lot of radioactivities, in some patients, over half of the radioactivity administered to the patient will come out in the urine, and that urine is very hot. And if you were to touch it or ingest it, the electrons from the radioactivity in the urine can injure you. So I just want to highlight that there's multiple types of radiation. That radiation can have different types of toxicities, and in the patient is primarily the beta particles, or the electrons, causing the injury. In the family members, it's going to be the emitted dose, the gamma and the photons, that's going to potentially cause injury, but also possibly the urine. So urine you want to be careful with, because there is a potential for high injury with the beta particles that's emitted from the urine, but it's very easy, obviously, to get rid of urine. So typically, that doesn't cause a lot of dose to patients and or family members around the patient. Now, risks associated with emitted dose. When we first started treating patients with lutetium dotatate, you can measure the activity being emitted from the patient, right? So you can use a radiation detector and measure how much radioactivity is being emitted. And patients measure roughly 2 millirem an hour if you measure 1 meter away from the patient at the time of dosing. So you administer the radioactivity, you measure them, they measure 2 millirem an hour. If you wait till the time of discharge, which is usually about 4 to 5 hours later, right, because you have to give all those amino acids, the measurement is about 1 millirem an hour at the time of discharge. In all honesty, what are we talking about? 2 millirem an hour, 1 millirem an hour? What do these units mean to you as a family member who's taking care or being around a patient? So to put this in perspective, I tried to convert this into some of the units we might be more familiar with. So 100 millirem is equal to 1 millisievert. Okay, it's not exactly perfect, but think about it that way. So 100 millirem equals 1 millisievert. Now, I put down here the dose associated with many things that go on in the world. So, for example, if you were to fly from San Francisco to New York City, you'll be exposed to 0.05 millisieverts. Okay. If you got a chest X-ray, you would be exposed to 0.1 millisieverts. If the average yearly annual dose, just living in the United States, is 3 millisieverts, a CT of the abdomen and pelvis, which no one ever thinks about having dose, actually exposes you to about 10 millisieverts of radioactivity. So if you're a family member and you're standing next to a patient, how much dose are you going to be exposed to? So 1 meter away. If I stand there for 10 hours, right? I'm 10 hours, I'm 1 meter, 3 feet away from a patient who was just treated the day of treatment, then I will receive 10 millirem, right? So you can see 1 millirem per hour. I multiply that by 10 hours, I get 10 millirem. 10 millirem is equal to, in essence, 0.1 millisieverts. So that's equivalent to a chest X-ray. So the dose you would get as a family member standing 3 feet away from a patient who was just treated the day of is equivalent to a chest X-ray. 5 hours is equivalent to the dose from flying to New York. So overall, the point I want to get across, and hopefully this is not getting across the point in the opposite ways, it's actually not a lot of dose, right? Most of us don't stand 3 feet away from a patient for 10 hours straight. And if you did, the dose that you would receive is equivalent to about a chest X-ray. So it's not a super high dose that we're talking about, okay? So I just wanted to put into perspective the dose. Now, as patients urinate and pee out that radioactivity, the dose that's being exposed from that patient will go down over time. The amount of gamma rays being emitted goes down, and so the next day, it's even less, right? And as the radioactivity decays and gets excreted in the urine, less and less radioactivity is being emitted from the patient. Now, one thing I think is really important to take in mind is that age is really important in terms of people who are being exposed to radioactivity. So this is some data, and all of this data is not perfect, but if we were to think about the risk of cancer from being exposed to 1,000 millisieverts, okay, a very high dose, much higher than we're talking about, right? So I said 0.1 millisieverts was standing next to a patient for 10 hours. This is 10,000 times more dose, okay? So the rates of lifetime risk of radiation-induced cancer here is obviously a real number, and we don't want anyone to be near these numbers, but what we're talking about from exposure here is much, much lower. But if you look at the age at time of exposure, you can see that when you're young, maybe 10 years, 5 years old, the risk of lifetime radiation-induced cancers is something like 14% from 1,000 millisieverts, a huge dose, right? We're not talking about that again. Now, as the person receiving this energy gets older, when you get down to 40 or so, it sort of plateaus and then goes down even further. Usually I think about when you're 40 to 50, these doses start to become less and less important. So, once you become my age, I care less. But if you have young children at home, these are people you want to be extra cautious about. And I'm over cautious when it comes to recommendations for kids. Obviously, I have young children, and I would want to be over cautious with them as well. But just want to point out that age is a really important thing in terms of a radiation risk from the exposure from the gamma photons. Okay, again, 1,000 millisieverts is very high. We're nowhere near this number. Okay, now in radiology, we have this principle called ALARA, and it stands for as low as reasonably achievable. And what this means is that in radiology, we actually don't really know the impact of these low doses of radiation. It's nearly impossible to measure whether or not there actually is an increased rate of cancer when you're having such low exposures. When I'm talking about 0.1 millisieverts, it's very, very low, and it's very hard to tell and measure that to see if it actually impacts a patient's or family member's lifetime risk of cancer. But nonetheless, we believe that it's not helpful, and so we want to minimize as much as possible, as reasonably achievable, the dose patients and family members receive. So there's a lot of caution in the way that we make recommendations to patients and their family members. So in terms of minimizing radiation exposure, I'll go through 3 or so criteria that you want to think about. So first, right, we're going to inject that radioactivity, and the radiation is going to come out in gamma rays. It's going to be, in essence, emitted all around a patient who is just treated with lutetium dotatate. First is time. Okay, if you want to minimize radiation exposure to people around you, you minimize the time that those people are exposed to you. Okay, so that can be being in a different room, that can be using a different restroom, that can be spending time by yourself if you want to minimize exposure to those around you. The second is distance. Okay, now if you double the distance, you in essence have the radioactivity, right? So the dose decreases by the square of the distance, and this is actually the easiest way to minimize dose. So remember when I said we measure 1 meter away, and it's about 1 millirem an hour at time of discharge. If you double that dose, you're going to have the amount of radioactivity that that device is going to measure. So if you want to minimize exposure, you just move further away. And if you get more than 6 feet away from someone, the dose in essence gets so low, it's not relevant anymore. So 6 feet away, very safe, stay safe. Now in the world, if you're rarely closer than 6 feet to someone because of COVID, we're used to measuring 6 feet in our minds now. So 6 feet away, very safe and a good way to minimize exposure to those around you. The last one is shielding. This is what we talk about in hospitals a lot. As you'll see, if you come in to get treatments, there'll be what we call an L block, which is a lead shield to prevent exposure to the technologists. And all of those things are done is because our nuclear medicine technologists are handling these radioactivities frequently. And because of the frequency, they really need to minimize exposure to themselves so that they don't cause injury to themselves. In the patient setting, shielding is not as important. You're not going to use a lead shield at your house or something to minimize exposure. These are the recommendations that we came up with now 2 years ago in our lutetium dotatate guidelines. So the first one here is sleep. We recommend sleeping in a separate bed and avoid intimate contact, and particularly for infants, children, or a pregnant partner, that should be extended. Sometimes I'm less strict with the sleep portion. What I mean by that is if you're in a king bed and you are over 3 feet away, the dose is pretty low, and also depends on your partner's age. If you're, retirement age, this type of exposure of one extra chest X-ray for a couple nights is probably not going to be clinically relevant to you or your partner. But sleeping is one way, because that is a long period of time where you could potentially be close together, right? So if you are very close together in bed for 10 hours, that's going to be a much different exposure than if you sleep on the opposite sides of the bed for 10 hours. So again, taking into mind distance is really important. The second one is urination. We recommend, and this is particularly important for men, to sit down while you urinate and flush the toilet twice with the lid closed after each use. Okay, you want to make sure that you clean off the urine, get it into the toilet, and that is because the urine can have beta particle exposure. The electrons are in that urine and can expose people who sit back down in the toilet. So for 3 days, you want to urinate sitting down, double flush, get the urine down the toilet. And then in general recommendations, for 3 days, we also recommend trying not to get closer than 3 feet for more than 1 hour with people around you, trying to maintain that distance of 6 feet, minimizing public transportation or public facilities if you can, and then return to work after 3 days. Usually that's because patients can feel tired after treatment, but you just want to be careful and minimize exposure to those around you. So take-home points from this talk. First, radiation exposure from external beam radiation therapy and targeted radionuclide therapies, or PRT, are very different. Right? From external beam, when you turn off the radioactivity source, there's no more exposure to the patient or family members around them. With PRT, the radioactivity continues for weeks and can expose both patients and family members for a long period of time. In terms of PRT, number 2 here, the dose to the patient, which results in toxicity, is from beta particles, the electrons. The beta particles or electrons do not interact with family members. It's the gamma emission, number 3 there, that will result in exposure to family members. But remember, the overall dose rate from gamma emission is very low. So again, 10 hours, 3 feet away from a patient who is just treated, exposes a family member to equivalent of 1 chest X-ray. Okay, and I think that sort of helps put in perspective this dose a little bit. 5 hours is a flight from San Francisco to New York. And now number 4, remember ways to minimize exposure: time, distance, and shielding, right? So you want to increase your distance, 6 feet or more, decrease the amount of time that you spend close to someone, and if you want, make sure you, not if you want, but after you're treated, urinate sitting down and keep the urine in there. And the way I try to remember number 4 the most is if you have young kids at your house, I know that I'd read to my kids a lot. I used to put them on my lap and read to them. What you don't want is very close proximity for a long period of time with a young family member, right? I don't even know if that would cause any toxicity. It's still a very low dose, but in the principle of ALARA, trying to minimize exposure as much as possible, you want to try to prevent things like that. So thank you very much. This is my email address, and I look forward to any questions and discussions on the topic moving forward. Thank you.
Hi, my name is Charlie Nutting. I'm an interventional radiologist in private practice in Denver, Colorado. I'd like to thank LACNETS today for inviting me to speak about liver-directed therapies. Why are treatment of liver tumors important? Well, about half the patients who present with neuroendocrine disease will have liver tumors at the time of diagnosis, and that increases up to 90% over their lifetime. Liver tumors, by their nature, start to replace the normal liver tissue and can push the normal liver tissue out of the way. So it's our job to try and keep the liver as healthy as long as possible. By treating these tumors, we can help preserve the liver function and also decrease symptoms related to these tumors. We've known for years that cytoreductive therapy or debulking of the tumors is going to help patients long term. Number one, it helps decrease symptoms such as diarrhea or flushing, and it can also help preserve liver function over time. Those are the main goals of cytoreductive therapy. As an interventional radiologist, when I look at patients, I look at their imaging, and we can see that this patient here on the left side has one small tumor in the backside of the right lobe of the liver. That's that little black dot. And that's a very different disease than we see in the patient on the right side who has multiple black dots spread throughout the liver. Those livers are actually treated very differently. So how do we decide which tumors to treat in which fashion? Well, if you have relatively small tumors that are less than 3 centimeters in size and less than 3 in total, we can use local ablative techniques. Patients who have more diffuse disease that spread throughout the liver, both sides, or in difficult to reach locations, then we'll consider regional liver therapies. Local ablative techniques. The ultimate local ablative technique really is surgical resection. So if you can take that tumor out, that's the best way to get rid of it. There are also minimally invasive procedures that allow us to insert a needle and either heat up the tissue with microwave or radiofrequency ablation. We can also freeze the tissue with cryoablation, or in special circumstances, we can shock the tumor into dying with irreversible electroporation. This is just a cartoon of a microwave ablation, but it can be translated into other ablative techniques. With microwave ablation, we're inserting a needle, which is really just a sharp antenna, into the tumor. We then turn on the energy that creates frictional energy and heats up the tumor to the point where it cannot survive. On this pre-procedural image, we see that there's a 3 centimeter tumor within the backside of the right lobe of the liver. That's the dark area there within the circle. We turn on that energy. Usually takes about 10 to 15 minutes to desiccate the tumor. The 6-month image shows that this area is dead. There's no contrast enhancement in that area. And at 1 year, we can see that cell death persists, and there's been a little bit of scarring of the liver with capsular retraction, which is actually a good sign of treatment. As we move on to regional liver therapies, or if the disease is too diffuse to put a needle in or do surgery, then we start looking at treating these tumors through the arterial system. Embolization just means that we're putting a product into the artery that gets carried downstream. Bland embolization is just a bead that creates ischemia and cell death. Chemoembolization is where we mix these beads with chemotherapy, and that chemotherapy dwells in the area along with the ischemia. Drug-eluting beads are beads that are soaked in chemotherapy and infused into the artery. Once they hit their location, they slowly elute chemotherapy, And there's actually been some issues with this technology in neuroendocrine patients that we'll address a little bit later. Radioembolization, the particle contains radioactivity, and then there's also isolated percutaneous hepatic perfusion. Regional liver therapy is accomplished by inserting a small tube into the arterial system, usually from the groin or wrist area. Under X-ray guidance, the catheter is then advanced into the blood supply of the liver. A smaller catheter or microcatheter is manipulated into the blood supply of the tumor itself. Small beads are then dribbled into the arterial blood supply. These travel downstream and become lodged at the precapillary level, where they exert their local effect. This technique is the same whether we're performing bland embolization, chemoembolization, or radioembolization. These therapies help kill the tumors from the inside. The NCCN guidelines call out liver-directed therapy for liver-dominant disease. And when we get to this category, there are specific caveats that they talk about. There has not been a study, a prospective randomized controlled study, looking at bland embolization versus chemoembolization in patients being treated for neuroendocrine disease. So in general, these therapies are considered comparable. Drug-eluting bead recently in the RETNET trial has showed that there's an unacceptably high complication rate with some biliary complications. So that really has been taken off the table. Most patients are being treated with bland or chemoembolization. TARE or radioembolization has been shown to be safer in patients who have bilioenteric anastomosis, which means that they have had a Whipple procedure. They could have a stent in their biliary tree. It's safer to treat these patients with Y90 than it is with bland or chemoembolization. And there's also some data that's coming out demonstrating that Y90 may have some toxicities, long-lasting toxicities, because we know neuroendocrine patients are going to survive for a long time. So really, we're looking at the long-term game. When we talk about embolization therapy, what are we trying to accomplish? Well, in general, you want to make patients feel better and control their symptoms. We want to improve overall survival, and we want to provide local control in the area of the tumor to keep the liver healthy as long as possible. Some of the questions that come up is, are these therapies safe? How long do they last? And then specifically with Y90 radioembolization, can that be used after patients have received PRRT? This is a meta-analysis from 2012 looking at clinical response in patients who had transarterial chemoembolization, and 85% of patients derived significant benefit from chemoembolization. So this is really a well-tested therapy that works great in patients that have liver-dominant disease. We also want to try and debulk these tumors. This is radiographic debulking, looking at patients who have been treated and then do follow-up scans. And up to 89% of patients do get significant debulking with a mean of about 55%. So it is safe, it is effective. This is a study, actually a survey in 2012 of interventional radiologists discussing how they treat these tumors based on tumor type. So in metastatic neuroendocrine disease, we can see that it was pretty evenly spread between particle embolization, bland, drug-eluting beads, Y90, and chemoembolization. I would say that this has probably shifted over the last 3 to 5 years to much more bland and chemoembolization, with radioembolization being used subsegmentally. It's important for you to talk to your physician, your interventional radiologist, about how are they going to prophylax you against a carcinoid reaction in patients who have functioning tumors. So at our institute, we give IV octreotide, usually 100 micrograms subcutaneously or intravenously right before the procedure. In patients that we know are labile, have labile disease, because as we embolize these tumors, they're going to get angry and secrete their proteins and hormones. We will mix up a bag and we will titrate it, or we'll drip it in based on symptoms. And it's very easy to speed it up or take it down. We tend to run the octreotide for about 2 to 4 hours after the embolization procedure. I'm going to look at a couple of papers here. This is a multi-center retrospective review. on 244 patients who have neuroendocrine liver metastases that were treated with resin spheres, or the trade name is SIRSphere. You can see it's uncommon for the tumors to go away, which is a complete response. It's much more common to see a partial response or stable disease. And only 9% of these patients actually had progression of disease after the radioembolization. The symptoms were alleviated in 79% of patients, and it was uncommon to have complications, but those complications could include a gastric ulcer if the beads go outside of the intended vascular bed, or RILD, radiation-induced liver disease, which we'll talk about a little bit more. This was a study out of Northwestern University looking at long-term hepatotoxicity of Y90. It was a single center review, and they followed these patients for 2 years after the radioembolization. They looked at 54 patients, and they used glass microspheres or Theraspheres, which in general tend to be hotter, a more radioactive sphere than the SIRSphere. And they saw that 27% of these patients developed a scarring of the liver. It looks like cirrhosis, and 13% of them developed ascites. It was more common in patients who received whole liver treatments versus lobar infusions. And by lobar infusions, I mean right lobe, left lobe, and you can also infuse the segments. There are 8 segments within the liver. So the less liver you treat, the safer the therapies are. This is a single center review looking at hepatotoxicity by Dr. Curry. The interesting thing about this is they looked at both Y90 products, SIRSphere and Therasphere. Only half of these patients had neuroendocrine disease, and what they saw was RECT, or RILD, occurred in only about 13% of patients, and it was more common with the glass spheres than it was with the resin spheres. Is Y90 safe after receiving PRRT? This is a multi-center retrospective review looking at 44 patients who underwent Y90 procedures after PRRT. There's still good disease control rate of about 91% at 3 months, clinical response in 65% of patients, and the overall survival was 3.5 years. There were toxicities, but they were relatively rare, with lymphopenia, meaning a decreased white blood count that rebounded, and RILD, which is radiation-induced liver disease, in about 2% of patients. Dr. Sulin and others also looked at this patient population and found that people or patients who had been heavily pre-treated with liver-directed therapy and received PRRT did have some significant adverse events. So if we look at the outcomes from embolization therapy, it does control symptoms in 75 to 80% of patients. We are good at debulking the disease, and the durability is somewhere between 18 and 30 months. Y90 is safe and effective after PRRT, and really what we're trying to do is keep the liver as healthy as we can for as long as possible. Morbidity or serious adverse events is relatively rare, with a very low mortality rate. This is a study that Dr. Sulin has put together. It's a randomized controlled trial, which is really the gold standard in medical therapy, looking at bland embolization versus chemoembolization versus drug-eluting beads in patients with neuroendocrine liver metastases. This is ongoing. We don't have the data yet. The drug-eluting bead arm has been dropped due to an interim analysis evaluating and identifying increased toxicity. Some of the other procedures that we have available in interventional radiology is portal vein embolization. Portal vein embolization allows us to treat the affected side of the liver and grow the other side of the liver. These patients who are going to undergo surgery to remove a portion of the tumor need to have enough normal liver tissue to survive. So if a patient has a right-sided tumor, we can do a right-sided portal vein embolization, grow the left side of the liver prior to surgical resection. We can also do the same thing with radioembolization. This is a patient who has large right-sided liver tumor burden. They underwent high-dose radioembolization of the right side to treat the tumors and to actually grow the left side of the liver. The patient underwent surgical resection to have the right side removed, and there was no evidence of disease on follow-up scans. Our clinical practice in Denver, I'm very fortunate to work with Dr. Eric Liu and Alan Cohn at the Neuroendocrine Institute. at Rocky Mountain Cancer Center. We have multidisciplinary tumor boards that allow us to discuss patients, review images, talk about sequence of therapies, and it really is a multidisciplinary review board. The way that we treat liver tumors, we tend to use bland embolization in a lobar fashion, meaning that if patient has diffuse bilobar disease, we would treat the right side of the liver first with a bland embolization. Patient would recover, come back 1 month later, and we treat the left lobe. Dr. Liu also has a program of sequencing bland embolization in between PRRT. We really reserve Y90 for segmental or unilobar infusions. Occasionally we'll treat whole liver, but that's much less common than it was in the past. We'll use high-dose radioembolization, or as we call it, selective radioembolization for difficult surgical areas. So tumors that are in segment 7 and 8, which is underneath the right side of the diaphragm, or central tumors are difficult to surgically remove, we'll use high-dose Y90 in those settings. Most of our procedures are performed in the clinic or outpatient hospital setting. It's relatively uncommon to admit patients to the hospital. On the left side of this picture, a patient has 2 tumors in the left lobe of the liver. Those are those brighter white spots that we see. This was an MR that was taken 1 month prior to the radioembolization. The middle live picture is injection of contrast material into the left hepatic artery. You can see those tumors blush or light up, become darker because of the increased blood supply that they have. So this was segmental radioembolization of 2 left lobe liver tumors. And then the right-sided MRI demonstrates the lack of blood supply or darkness, which is necrosis in the area where those tumors used to be. So in conclusion, embolization therapy is effective at debulking and helps control neuroendocrine liver metastases. And the real key of all this is to keep the liver as healthy for as long as possible. It's important to sequence these things, whether it's biologics, chemotherapy, or surgery and liver-directed therapy. And I really think collaboration is key. With a complex, relatively rare disease, it's good to have a team of people discussing you. I would stay away from drug-eluting beads in general for neuroendocrine tumor embolization. It is safe to use Y90 in lobar or segmental infusions, and you can treat patients who have undergone PRRT in the past. I'd like to thank LACNETS for allowing me to present this, and hope you guys have a great day.
Thank you, Dr. Heft-Donnerson, Dr. Hope, and Dr. Nutting for those fascinating presentations. In this third section, we will discuss symptom management and complementary medicine. While we focus quite a bit of attention on treating the disease, quality of life is important, and that means managing symptoms so we feel good and can get back to the things we enjoy. So I'm curious to hear from each of you. What would you say to a NET patient about managing their symptoms? Dr. Hendefar, let's start with you.
Thank you, Lisa. I definitely agree that managing symptoms are super important. My recommendation would be, as the symptoms, if your symptoms are getting worse, you might need to make your treatment team a little bit bigger and get some more expertise involved, whether it could be GI symptoms or pain symptoms. There are practitioners who specialize in those fields that could sometimes really help. And sometimes you want to even expand your team to alternative practitioners. And in general, that's really recommended. Although I would say the caveat is make sure that if you're taking any supplements or any other medications or therapies, that you would seek out the approval of your primary oncologist or physician.
My advice is really, again, stay in tune. We know that many symptoms are very individualized. So be in tune about your body and how you're feeling. And I think it's really important to write down all of your symptoms and essentially keep notes on your symptoms so that you can really share the details of these symptoms with your care providers so that they can get a good handle in terms of what's the best way to address those symptoms.
I would say that I've found getting involved in your local support group or even a national support group and speaking and networking with other patients is truly one of the most beneficial and comforting things you can do as a patient. as you connect with other patients, you feel like you're not alone, and you can get invaluable information from other patients dealing with the same symptoms, and they can give you suggestions that you may not have even considered prior.
Similar to my co-moderators, symptoms and side effects are unique to each one of us. Even though we are all zebras, our stripes are uniquely our own. So it's important to follow up with your doctor and let them know what is happening, and know that no symptom or side effect, no stripe that you're experiencing is too big or too small to go unmentioned.
Thank you, all four of you. What wise words of wisdom. So now we're excited to introduce our next set of speakers. I'll hand it off to you, Beth.
I'm very excited to introduce our next speaker. She is an amazing woman, a dear friend, and a fellow NetConnect mentor. Val has been living with carcinoid syndrome, but Val has also been an example of one who thrives with this disease. And through her story, I hope that you're all inspired as much as I am.
I'm very pleased to introduce Dr. Del Riviero, who is an endocrinologist and oncologist from the National Institutes of Health. Title of the talk is Symptom Management.
And I am honored to introduce Dr. Narjus Duma, who is a thoracic medical oncologist from Dana-Farber Cancer Institute in Boston. And she has been an amazing mentor to many junior physicians around the United States, and has been certainly a patient advocate as well for patients. And the title of her talk is going to be focusing on complementary medicine.
Thank you. And for our Spanish-speaking audience, both Dr. Del Riviero and Dr. Duma's presentation are also available to view in Spanish on our website. Again, that's www.lacnets.org/Spanish resources. Thank you to our silver sponsors, Novartis and Tercera.
Hi, I'm Valerie, and I'm going to talk to you about carcinoid syndrome. In October of 2015, I was diagnosed with carcinoid syndrome. Like many patients, I struggled with symptoms for years, but it was this racing heart, the tachycardia, that sent me to the cardiologist to try and figure out what was going on. He did all the cardiac tests. Everything turned out great. There's no problems there, so I was grateful for that. But what was it? Well, he did a 24-hour urine test, the 5-HIAA, and it came back elevated. That's what started me on my neuroendocrine journey. I was able to find a doctor that was able to think outside the box and help me to manage this. I didn't have a biopsy-confirmed diagnosis from a tumor, so he said, let's just try the octreotide and see if that doesn't work for you. So I tried it out. I did self-injections, which I thought I'd never be able to do. Having to stick a needle in my abdomen, that wasn't going to happen. But I did it. I was very grateful for it. It gave me quality of life. I felt so much better. I stopped the tachycardia. I had some energy. I didn't have to make as many trips to the bathroom. So I was very grateful for this medication, and very grateful for a doctor who decided to at least give me a trial on it. Then I was put on the Sandostatin LAR, the long-acting. That worked well. I didn't have to do as many injections, and then I was switched to the lanreotide. That is what I continue to take today. I take it every 21 days rather than the typical 28. I still have to do rescue shots every day. Some days are worse than others, but it helps me to control my symptoms, and it also helps to give me quality of life. Now, these injections can be delivered one of several ways. You can have a vial that you fill up a syringe with, and can give yourself injections that way. You can get the pre-filled syringes, which is what I prefer. And those I can just throw on my purse and take with me. A lot of people are looking at the pen, which is pre-filled and can stay unrefrigerated for 28 days. So there's different options for you. A lot's going to depend on what your doctor can prescribe for you, and it also depends on what your insurance will cover. So please take a look at both of those things to determine the best solution for you. Not everyone needs rescue shots, so that's great. But if you do, it's good to know that you do have options available to you. Some NET patients also can be sensitive to drugs ending in INE. For many years, I struggled every time I had to get a cortisone injection, went to the dentist where I got the Novocaine. I would just kind of check out. I'd feel horrible. I'd have nausea. Just didn't know what was going on. I'd struggle to breathe. And then it would kind of resolve itself after time. But why was this happening to me? Well, after my carcinoid diagnosis, I determined that's what was going on. So that's what also helps with the rescue shots. When I get these symptoms, it will help with that. It takes about 5 to 10 minutes, and it gets resolved and everything is fine. NET patients who have functional tumors need to be aware of the 5 E's. 5 E's that set off a syndrome attack could be epinephrine, exercise, emotion, eating, and ethanol, which is the alcohol. Exertion like heavy vacuuming, heavy lifting, anything that causes any type of true exertion will also set off my syndrome. So that's why I am very grateful for my cleaning lady. She takes care of all the heavy lifting and exertion for me, so life is good. But not everyone gets this, so you can't justify the cleaning lady all the time, but it does work for me. Everyone is different. Some people get the syndrome attacks, some don't. I know of a number of patients that don't have any issues with that, but some that do are very grateful for the rescue shots. Random itching can also be a problem for NET patients. Hydroxyzine works well for me. I take it at night. If I have additional itching during the course of the day, I can take another one. Zermello has been known to help a lot of patients that have the diarrhea. Both of these medications are under a doctor's prescription, so make sure that you do check with your doctor to make sure that it is the right medication for you as well. It can be adjusted depending on how much you're suffering with the symptoms. Constipation can also be an issue for a lot of patients. I've been taking magnesium capsules for many years, even before my diagnosis, because I struggled, didn't know what it was between the diarrhea, the constipation, and I've been taking the magnesium tablets at night or taking the magnesium capsules at night. That seems to work very well for me because I can also adjust it. If I'm having more diarrhea, then I back off on the magnesium. Some patients take the Miralax, some take the stool softeners, but it's most important that you do discuss this with your doctor and get the right combination that works best for your particular situation. Rest when you need to. Give yourself grace when you struggle to do even the simplest of tasks on a daily basis. We all have different experiences, but I was very grateful to find LACNETS in my early diagnosis. They have been tremendously helpful for me as far as seminars, getting me in touch with certain experts, online support. They do have a Net Connect Buddy program so that you can be connected to another patient that has similar symptoms to you and may have certain diagnosis that is pertinent to what your situation is. So I would highly recommend getting on lacnets.org and seeing for yourself what they do have to offer. Talking to others who experience the same symptoms has been very helpful. Listening to experts in that field has helped give me hope and comfort. And we just want to let you know you're not alone in your journey. We're here to help you. Thank you.
Hello, everyone. It is a pleasure for me to be with you all today and discuss about management of functional neuroendocrine tumors. First, let's discuss about neuroendocrine tumors and its hormones. Neuroendocrine tumors are a diverse group of neoplasms that can originate from endocrine cells, and that can affect everyone in the body, as we can see here in this figure. They are classified by their size of origin, and the neuroendocrine cells secrete a vasoactive peptides or also hormones. Depending on where the tumor is localized, they can't secrete a specific hormones, and depending on what hormone they secrete, they can also have a very specific clinical presentation. Just to give you an example here, for example, pheochromocytoma is a neuroendocrine tumor of the adrenal gland, and these pheochromocytomas can secrete an excess of catecholamines and metanephrines, and that translates what we call a fight or flight response, and they have very specific clinical manifestations. We will discuss more in detail about the pancreas neuroendocrine tumors as well as the small bowel neuroendocrine tumors. And the small bowel neuroendocrine tumors, they can also produce a hormone called serotonin, and that translates in the urine in the form of 5-hydroxyndolacetic acid. Small bowel neuroendocrine tumors and pancreas neuroendocrine tumors are the most common neuroendocrine tumors in the body, and we'll discuss more in detail about that. Now, in terms of the clinical presentation of neuroendocrine tumors, most commonly they're non-functional, meaning that they don't produce hormones and they have non-specific symptoms. More functional neuroendocrine tumors accounts for about 40% of all neuroendocrine tumors, and they secrete hormones, and depending on the hormones that they secrete, they have very specific clinical manifestations. Among the non-specific symptoms related to the neuroendocrine tumors, it can mimic a variety of disorders. Some of these symptoms can be abdominal pain or abdominal discomfort, weight loss. Some of these neuroendocrine tumors may have fibrosis, scar tissue tumor, and that can also cause a small bowel obstruction. It can also cause addition of the sentinel loops. Depending on where the neuroendocrine tumor is localized, it can also obstruct the bile ducts, and that can also cause jaundice. It can also cause nausea as well as gastrointestinal bleeding. These neuroendocrine tumors, they go often to the doctors, and then often they're referred to the gastroenterologist. The unfortunate thing about these neuroendocrine tumors is that they can mimic a variety of disorders. Sometimes we are diagnosed late. These neuroendocrine tumors have a delayed diagnosis, and that's something that we need to do better about that. In terms of other symptoms, often these neuroendocrine tumors are misdiagnosed with irritable bowel syndrome. Now, let's discuss about functional gastroenteropancreatic neuroendocrine tumors, and there are neuroendocrine tumors of the pancreas or the small bowel, and we'll discuss briefly about pancreas neuroendocrine tumors. So gastrinoma is a neuroendocrine tumor of the pancreas. It produces gastrin, is a hormone that increases the acid secretion in the stomach, and that can translate into specific symptoms of ulcer formation and diarrhea. And that's the name for that is Zollinger-Ellison syndrome. What is an insulinoma? Insulinoma is a neuroendocrine tumor that produces insulin, and this excess insulin can cause hypoglycemia. VIP-OMA, or vasoactive intestinal peptide, these are very rare neuroendocrine tumors, and VIP is basically a hormone that stimulates the secretion of water as one of electrolytes. And this patient may have severe diarrhea, profound diarrhea, and electrolyte abnormalities. Glucagon is a hormone that causes the liver to convert glycogen into glucose in the circulation. And what that means is that this excess of glucose can also be responsible for diabetes mellitus, sometimes uncontrolled, and other symptoms as well, like skin rashes and other symptoms associated with glucagonoma. What is somatostatinoma? Somatostatinoma is a neuroendocrine tumor that produces somatostatin, and somatostatin can also inhibit insulin, and that can also, this inhibition of insulin can also cause diabetes as well as other symptoms. And carcinoid, what is carcinoid? Carcinoid is a neuroendocrine tumor likely localized in the small bowel. We also see in the lungs as well, but carcinoid tumors can produce excess of serotonin and other bioactive peptides as well. And these bioactive peptides, or these hormones, can then translate into the symptoms associated with diarrhea, flushing, and other symptoms. Now let's discuss about carcinoid syndrome. What is carcinoid syndrome? Carcinoid syndrome is a constellation of symptoms. As we can see here, those constellation of symptoms, the most common is flushing. And flushing can also be caused spontaneously, meaning that there is no any causes that can produce flushes. But there are certain factors that can exacerbate this flushing. And that's when the 5Es comes into a role. What is the 5Es? 5Es stand for eating. So there are certain foods that can exacerbate this flushing. And that's mainly avocados, bananas, nuts, chocolate, emotions, or excessive emotions, ethanol or alcohol can also exacerbate these flushings, and these flushings can be more exacerbated throughout the body. Excessive exercise, but again, all these factors that may exacerbate the flushing may not happen to everyone. That's something that you can need to keep in mind. A lot of the time we see this flushing without any factors that exacerbate this flushing. But one important thing that I would like to mention is about epinephrine, which is part of the 5Es. I would like to clarify that patients that flushing, they are not allergic to epinephrine. epinephrine sometimes is important because it can be life-saving, especially in those patients that have severe allergies in which EpiPen is required. Sometimes epinephrine is found when you go to the doctor's office and they need to use local anesthesia that counts epinephrine. However, even though we know that sometimes, and it doesn't happen to everyone, can cause flushing, sometimes in order to prevent that, you may want to use what we call a rescue shots of octreotide, or now that we have easier administration with a pen. So this is important, that even though we know that this can occur, it doesn't happen to everyone, and it doesn't mean that it's an allergy to these factors. Now, other symptoms associated with carcinoid are diarrhea. We'll discuss more about the management of these symptoms. It can also, this excess of hormone or serotonin, it can also accumulate in the heart because it cannot be metabolized by the lungs, and that can also cause endocardial fibrosis, or it can also affect the heart pulse. And this is important when a patient has excess of serotonin or high amounts of serotonin, that they need to have a cardiac evaluation and echocardiogram as well. Now, in terms of the management of carcinoid syndrome, sometimes when these symptoms occur, that means that often they are advanced or they are found outside of the region, site of origin, meaning metastatic. And in those situations, we need to find a balance between symptom control of the carcinoid as well as control of the tumor proliferation. This endocrine important that needs to be discussed with a multidisciplinary team in order to discuss all the available treatment options and what will be the most beneficial to the patient. Sometimes in the metastatic setting, surgery is also an option for those patients, and we can also debulk, and that can also help to the symptom control. However, not every patient may be a candidate with surgery, and that's why all of these neuroendocrine tumors need to be discussed with a multidisciplinary team. All of you are familiar with octreotide or lanreotide. These drugs can also help control the symptoms of hormone excess. It can also decrease the secretion of serotonin. At the same time, we know that these medications can also help slow down the growth of the tumor. We will discuss more about telotristat. That is a medication that helps control the symptoms of diarrhea. Or when surgery is not indicated and we see disease in the liver, sometimes liver-directed therapies as ablation and embolization can also be an option here. PRT with Lutathera can also help control some of the hormone excess. At the same time, it can also have activity in the tumor. And everolimus is another treatment option that also is known to also decrease the amount of serotonin. In patients that require surgery, or in patients that may require some type of liver ablation and embolization, where general anesthesia is required, sometimes we also need give higher dose of octreotide before the procedure and during the procedure to also prevent the carcinocrisis. Now, let's discuss briefly about telotristat. We discussed that telotristat is a medication that helps minimize the symptoms of diarrhea. And why is that? As we can see in this figure in the bottom, tryptophan is converted to serotonin, and serotonin then it goes into the circulation and then is eliminated in the urine in the form of 5-hydroxyndolacetic acid. And what telotristat does is blocks the conversion from tryptophan to serotonin. As we can see here in this graph on your right, telotristat is also known to decrease the level of 5-hydroxyndolacetic acid, and because of that, that can also decrease the amount of bowel movements per day. So this is a medication that can be added in those patients that have refractory diarrhea, despite other medications that can help to control the symptoms. What is insulinoma? Insulinoma is a neuroendocrine tumor that produces excess of insulin. This excess of insulin then causes very low levels of blood glucose that can be very dangerous. And these low levels of glucose then cause a series of symptoms. These symptoms could be anywhere from shaky or increased heart rate or sweating or feeling anxious or hungry, irritable, headaches, having severe fatigue. And these symptoms are usually relieved with the ingestion of something that is very high in content of sugar. So that's what we call the Whipple's triad. It's low blood glucose that causes symptoms and is relieved by high levels of content of sugar. Now, in terms of the symptoms management of insulinomas, usually these insulinomas, they can be very symptomatic, even if it's localized in the pancreas or they're very small. So that's why it's important to localize and do surgery in those situations. Sometimes we need to, in order to minimize some of the symptoms, we can then recommend frequent meals with complex carbohydrates, as well as glucose intake, and sometimes IV glucose as well. There is a medication that also decrease the release of insulin at the level of the cell, and that's called diazoxide. And that's something that we need to discuss with your doctor. Other medications, as we all know, is octreotide and lanreotide, and those medications can also decrease the secretion of insulin. And of course, in the advanced setting, there are different treatments that can be used. Octreotide and lanreotide, as we discussed earlier, can also help to decrease the growth rate of these neuroendocrine tumors. And there are other treatments that you will hear around throughout your day today. Gastrin is a hormone that produces excess of acid in the stomach. These gastrinomas can be found in the pancreas as well as in the duodenal part of intestine. This excess of gastrin, or that translates in excess of acid in the stomach, can form multiple peptic ulcers. Other symptoms are diarrhea, heartburn, and weight loss. In those situations, it's very important that when we diagnose a patient with gastrinoma to use higher doses of what we call proton pump inhibitors, such as omeprazole or pantoprazole. Surgery is indicated when you're able to localize the gastrinoma as well. Sometimes these patients may have advanced disease, and those treatments that, as I mentioned here, it could be either from the octreotide, lanreotide can inhibit the production of gastrin, as well as other therapies directed to the liver if they're localized in the liver, or other systemic therapies. Now, there are other functional pancreatic neuroendocrine tumors, as mentioned here, depending on what the cell of origin is. As a VIPoma, glucagonoma, or somatostatinoma, they can produce a specific hormones, as we discussed earlier, and depending on the hormones, they can also have a specific symptoms. And based on these symptoms, we also need to provide general measurements based on those symptoms as well. I would like to mention something about management that help us to control the tumor growth as well as the hormone secretion. And the reason why it's important to mention is because sometimes when we provide these treatments, you may have symptoms that you may think that the tumor is exacerbated, but the reality may also be that it could be a side effect of the treatment as well. And that's why you always need to be in close communication with your physicians, and you also need to be very aware of what's going on as well, and always communicate with us as your provider or the person who is treating you. So the bulking surgery is always indicated in those patients that may have advanced disease. Usually the recommendation is that if you are able to, or we're able to reset, or the surgeons are able to reset at least 70% of the tumor bulk, that can definitely help to resect the clot, as we say, but at the same time, it can also help with this hormone excess. Octreotide and lanreotide, we're all familiar with this. One of the symptoms, it can also cause diarrhea, and this type of diarrhea is a malabsorptive diarrhea. And in those situations, to help those symptoms, we actually prescribe pancreatic enzymes. And that's also important because we know that it helps for those functional tumors to decrease the excess of hormones, but at the same time, in the non-functional tumors, it can also cause the symptoms, and that doesn't mean that your tumor is getting worse, but it's something that you need to be aware. It can also cause worsen your diabetes as well, but you need to work very closely with your endocrinologist to manage that. Other treatments mentioned here, for example, capecitabine or temozolomide, that can also cause diarrhea. It can make you fatigue, and as well as everolimus, that can also cause diarrhea, but that doesn't mean that your tumor is getting worse. It's possible that this could be a side effect of the medication, and that's why you need to be aware, and you need to discuss with your physician as well about this. Now, this is just a summary. Neuroendocrine tumors can be quite complex, and as we discussed here, there are different types of neuroendocrine tumors, and depending on what hormones they produce, they also have very specific presentation, as we discussed here and we discussed through our talk. In conclusion, functional neuroendocrine accounts for up to 40% of all neuroendocrine tumors. It's very important to have a proper biochemical evaluation in relationship to the clinical presentation, as well as extremely important to have adequate imaging studies as well to diagnose the neuroendocrine tumors. Surgery is the treatment, the cornerstone of treatment for these neuroendocrine tumors. It can also help to reduce the clinical symptoms in patients that they don't have localized disease, but more advanced. Cytoreductive techniques is also benefit in patients with metastatic functional neuroendocrine tumors. As we discussed earlier, additional measurements are needed to control the excess of hormones, depending on what neuroendocrine tumors is and what hormones they produce. And for advanced and metastatic settings, we discussed about octreotide or lanreotide to also help control the excess of hormone. At the same time, it has an anti-tumor effect as well. There are other treatments provided for the advanced metastatic neuroendocrine tumors that you're going to hear about today. But something that I would like to mention surofentanil was approved this month for the management of pancreatic and extrapancreatic neuroendocrine tumors as well in the advanced setting. With that, I would like to conclude my talk. I like to say that I would like to give my deepest thanks in the memory of Giovanna Invasi, that without her efforts and dedication, this may not have been occurred. I will always be very deeply to her and very thankful to her. And also, she's a wonderful champion, has been a wonderful champion for the NET community, and we will continue your vision through LACNETS. I thank you forever. I would also like to thank Lisa Jen, which is the program director of LACNETS, Linset, and the board of directors. It does take a village. And I thank you all for your tireless efforts to making a difference in our patients and in our NET community. And of course, I would like to thank our patients. We're filled with immense gratitude to all the patients, all the NET patients around the world, and we're always grateful to you, and you're our inspiration every day to do better and to develop better treatments for you. Thank you.
Hi everyone, my name is Dr. Narjus Duma. I'm an assistant professor of medicine and a medical oncologist that specializes in thoracic malignancies. We are focused on women with lung cancer. Today, I have the pleasure to talk with you about complementary therapy for patients with neuroendocrine cancers. I want to thank the organizing committee for the invitation. This is a subject that's often overlooked and not explored, despite many of our patients taking complementary medicine or integrative medicine. As per next month, my affiliation will change to the Dana-Farber Cancer Institute and the Law Center for Thoracic Oncology at Harvard Medical School, where I will be also the Associate Director of the Cancer Equity Program. These are my disclosures, which include advisory and consulting, as well as speaking engagements. Healthcare can be very complicated, particularly associated with cancer care. Our healthcare system is just full of dead ends and like U-turns. And when you try to search for information about complementary alternative or integrative medicine, that pathway becomes like the pathway on the blue and the slide. It can be very confusing, it can be very challenging, it can be very expensive. So I hope we can talk a little bit about what is complementary medicine and how these can be part of your journey in your cancer treatments. First, we need to talk about the difference with alternative and complementary medicine. They are different, and they're often used interchangeable when they're not. So alternative medicine uses the term that patients and caregivers are using a treatment instead of the conventional treatment. It means it's an alternative. So instead of getting, for some patients, chemotherapy, the patient pursues other types of therapy and does not get a standard of care. Complementary medicine is a different term and is a term that applies to what most patients with cancer do, which is medications and other techniques in which supplements the standard of care. The standard of care is what has been proven by clinical trials and by studies that helps our patients with cancer. So alternative is one instead of the other. Complementary is we are complementing the standard treatment. So complementary and integrative medicine are the terms that are approved and we're using more and more. Complementary medicine is the one that we're more familiar with. Integrative have the same concept in which is incorporated to the standard of care and is complemented to the conventional approaches. And this is what we're going to be talking about today, complementary and integrative medicine, understanding that these ones are here to support you during your cancer journey. So what includes complementary and integrative medicine? Include many, many things. It goes from supplements, procedures, techniques, and medications that helps our patients during their journey for their cancer treatment. Some of the more well-known includes acupuncture, herbs supplements, massage therapy, meditation. But there's also many other techniques that comes from outside of the country or we in our country that helps our patients during their journey. So there is no clear cut of something being complementary medicine. What defines what is complementary medicine is what our patients use to support them during their treatment. Something unique about complementary medicine is that it's very linked to our beliefs. is linked to our culture. So you may see practices are very different in the United States because our beliefs and our healthcare practices vary based in our ethnic background, based in our religious background, based in previous exposures during travels. So I may have many patients that have the same disease, in my case, patients with thoracic malignancies, but their beliefs are different and how they see complementary medicine is different. So for this case, there is no one remedy that is good for everybody because we know that complementary medicine is really linked to our culture. And these tea and these practices are linked to or how did we grow up, where did we grow up, and what do we believe in. And I'm mentioning this because it's important that there is no one complementary medicine better than the other. And unfortunately, many of them have not been tested in a clinical trial in a very strict scientific criteria. So the appropriate term is integrative oncology. Is the appropriate term describing all these remedies, supplements, and techniques that are here to support our patients and provide a holistic and multidisciplinary cancer care. Our patients are not defined by their disease, and we're here to help them during that journey. And one of the things that I want to encourage everyone is to have a very honest conversation with your doctor and anybody in your healthcare team about complementary medicine. There is no judgment. There is nothing that we will say is wrong. We just want to know to make sure these medications don't interact with your therapy. We want to know in case you have side effects and they may be secondary to the complementary therapy. And finally, we also want to make sure that you are safe, not only physically, but also emotionally and financially, as complementary medicine is associated with a lot of financial toxicity. And we're going to talk about that. So how can integrative or complementary medicine help our patients during the cancer care? Well, one of the things that it helps control the symptoms that the cancer treatment produces, the side effects of the radiation, the side effects of the chemotherapy, potentially side effects of surgery. It also helps with the stress related with cancer treatment, and also helps many of my patients feel like they have a little bit of control. Cancer disrupts everything, family relationships, lifestyles. So complementary medicine has the good side that my patients feel they have more control and they're doing something more, a little bit more to help their health. And he also proposed own wellness. Many of my patients did not had a very healthy lifestyle until the diagnosis of cancer. So this complementary medicine allows for general wellness. There's many other reasons why people use complementary medicine, and because complementary medicine is linked to our belief, to our culture, those reasons vary from person to person. And we are not here to judge, we're here to listen, to understand, and to work together. Because it's your journey, it's your cancer journey, and as your doctor, I'm here to guide you to the journey and to make decisions together. And complementary medicine is part of what you believe. So what are some of the benefits of complementary medicine? There has been studies about several of them, and we're going to talk about what we know more. So we know a lot about acupuncture, particularly in patients with breast cancer, but we're more and more learning about other patients. So it can help with chemotherapy-related anxiety, chemotherapy-related nausea and vomiting. It is important that we practice strict clean needle procedures, particularly now during the COVID-19 times. Ginger, I'm a big fan of ginger. Ginger helps control nausea secondary to the chemotherapy. It has to be used in conjunction with anti-nausea medication. My patients are big fans of candy ginger that you can buy anywhere, and it helps them with the nausea induced by chemotherapy. Yoga, limited studies, many studies in breast cancer suggest that yoga will help with distress, anxiety, depression, and the overall stress that our patients face with cancer. Other mind and body techniques, biofeedback, hypnosis. Some of my patients have used hypnosis to quit smoking and also help with their stress. Meditation techniques can help deal with some of the secondary or the side effects of cancer-directed therapy. And I like the practical aspect. So many of my patients are very cell phone savvy. I specialize in women with lung cancer. And I ask them to download Headspace or any other platform they have for meditation. No specific disclosure with that particular app, but I say when you're waiting for your scans, you can try to do a 5-minute meditation. When you're waiting in the waiting room, you can do a 10-minute meditation. So there's that practical aspect of complementary medicine. Do you want to get massage on the weekend? Do you want to go for walks? Those things are complementary medicine, and I really like it to incorporate it into the treatment. What about bringing the ginger to the chemo suite? I have patients that do yoga when they're getting the chemotherapy, of course, with communication with the nurses, and helps them the time that they're in the chemotherapy suite getting the infusion go faster. Massage therapy has helped relieve symptoms, depression, anxiety secondary to cancer. It is important that you have a good communication with the massage therapist, and there is avoid areas like where the skin is sensitive due to radiation, tumor areas, and you have to be careful about deep tissue massage, particularly if you're in chemotherapy due to the high risk for bruises. When can you use complementary medicine and integrative medicine? Well, you can use complementary and integrative medicine anytime during your cancer journey, during cancer prevention. Some of my patients use hypnosis to quit smoking. Early detection and diagnosis. A lot of my patients use techniques to help when they're waiting for a biopsy. That helps with the anxiety associated. During treatment, you can use our essential oils that you can smell to help with the nausea associated with the chemotherapy, to help sleep when you are in steroids for some reason for your treatment. And at the end of life, complementary medicine is important for getting a spiritual health. It is a part of complementary or integrative medicine. It's what we use to make the journey easier and complement the standard of care, because we have to see our patients as a whole, and many of these aspects of care are forgotten, and they're very important. I'm a big proponent of many of these little tricks that make our patients tolerate therapy better, like do dishes with gloves or use certain smells in the house, because the journey is long and is exhausting for many of our patients. So there are risks to complementary medicine. The main risk is that some of these dietary supplements, they're not controlled by the FDA. So some of them may be imported and it's not clear of the composition. And some of them may be very harmful. I lost a patient due to a supplement that came out of the country due to liver failure. So it is important that communication is there with your healthcare provider, with your pharmacist, to make sure these supplements are safe when interacting with your chemotherapy. There's a lot of pseudoscience that say, oh, this will be fine, but you need to make sure that your team knows about it. Particularly interactions. Some of these supplements may prevent the chemotherapy or the target therapy from being eliminated. So the medication stays in your body longer than it used to. And then you have very long-lasting side effects. It is important that we don't delay or avoid conventional treatment, because some of these complementary medicine has not been proven to help the cancer. They will help you, but they won't help the cancer. So delaying or avoiding conventional therapy needs to be very carefully discussed. And finally, financial toxicity. There's a lot of pseudoscience, and there's a lot of people that wants to help our patients, and we suggest certain complementary medicine, but these are not covered by the insurance. They tend to be very expensive, some of them, and some of them are harmful, and they're very expensive. So we already have a lot of financial toxicity in cancer care, and if you are not careful with this complementary and integrative medicine, then our patients can have tons and tons of debt secondary to these complementary magical medications, when in fact they have not been proven. So we have to be very careful. If something sounds very good, it's probably not. And these pictures just to reiterate that financial toxicity needs to be to take into account with complementary medicine, because it can get very expensive, and it can add to the burden later on and may don't help you. So have a communication with your doctor to make sure that medication doesn't interact, and be very careful about the pseudoscience, which is the claims that have not been proven of certain therapies to cure the cancer or to shrink the cancer. This is a few clips about supplements. Certain herbs like the kava herb has been associated with liver damage, and which patients die of liver failure. High dose B-carotene actually increases the chances of lung cancer. And these are just a few examples of what can be dangerous. Some supplements can make the skin very red, particularly the size of radiation. So some essential oils that are too concentrated can burn you if you put them right where you were radiated. And it can be very painful, and I have seen second and third degree burns with that. And there's also a lot of herbs that will interact with your therapy. For our patients with neuroendocrine cancers, they have a lot of oral agents, like some oral chemotherapies, like capecitabine, like temozolomide, everolimus. Some of these herbs can interact with these drugs, and they can, one, decrease efficacy, so it won't treat your cancer, and two, can make it very toxic. Coming to an end, I think it's very important that we know that these can interfere with chemotherapy, radiation, and other medications. You have to have an open line of communication with your doctor. There is no judgment. I see complementary medicine as a good thing. My patients do very well. I encourage them to read about it. And if you have a good relationship with your oncologist, there are things that you may try that your oncologist will learn. I learned about witch hazel for the rash induced by immunotherapy from a patient, and that's just complementary medicine. So we are a team, and there is no wrong or right. We are together. We just want to make sure that they doesn't interact or makes your treatment not work. And finally, the special considerations for patients with neuroendocrine cancers. Some of these cancers they produce hormones, and some of this complementary medicine can also produce hormones. So we want to make sure that the hormone that we're trying to block, you're not receiving it through the complementary medicine or the supplement. I saw that in a case of a pancreatic neuroendocrine tumor. So be careful that you're not supplementing the hormone that is actually keeping your cancer alive or cancer growing. And we are trying to learn more about neuroendocrine cancers, and that's why clinical trials are so important. If you are considered to join a clinical trial, you need to be also very upfront and make sure you notify them about any supplements, or any procedures, or any techniques, because that can jeopardize the opportunity to be in a clinical trial, or if you're in a clinical trial, that can actually affect your outcome in the clinical trial. So we have to have an open communication. I want to thank all of you. Open communication, we need to be careful, financial toxicity, and if you have any questions, feel free to reach out to your doctor, to your pharmacist, or to me if I'm available. Thank you, everyone.
Thank you, Val, for inspiring us with your story. And thank you, Dr. Del Riviero and Dr. Duma, for your excellent presentations. In this final section, we're discussing research, advocacy, and support. So let's hear from each of you. What would you say to a NET patient in regards to NET research, patient advocacy, or support? Dr. Hedafar, let's start with you.
Yeah, thank you, Lisa. I think it's very important that our patients get involved in advocacy. It's really important that we support LACNETS, that we join together in these meetings and do everything we can to help the community at large. So, please support LACNETS as much as you can.
So I'm going to focus a little bit on NET research. I think there's a lot of very innovative research that's going on, whether it's clinical trials or more patient-related outcomes research as well. My most important advice is that timing for clinical trials matters a lot. So really take advantage and talk to your providers to figure out what is the right time to go on certain types of clinical trials, and really, take part with that to make sure that the timing is correct. And you sometimes don't want to wait until it's very late or later on to go on a clinical trial. And sometimes going on a clinical trial earlier might make a lot of sense for your journey.
Yeah, so speaking of clinical trials, it was very instrumental in my treatment, and I just wanted to kind of share that aspect of mine. So I actually started a clinical trial 7 years into my diagnosis, and I'm proud to say that 9 years later, I'm still on the same treatment protocol and with stable metastases. So as much as clinical trials can be useful at the beginning of a diagnosis, you should keep an open mind and open communication with your doctor to see if there are trials available to you as your treatment progresses, or your cancer possibly progresses as well, because there's options all along the road.
I'm going to speak in regards to patient advocacy in the sense of you'll quickly learn through this process that, and especially living with something as rare as NET, that you will become an advocate. And through that path, you learn that advocacy is something that you learn to do, and that you realize that through your own need for being an advocate, that others need advocacy. And advocacy incorporates research, support, and education. And that's what it means to be an advocate for yourself and for others. And I'd like to hand this kind of topic over to my dear friend Mary, who's going to share a little bit more about what it means to advocate for yourself and for others.
So I am proud to present the Monica Warner Award, annually presented to a patient, a supporter, or a caregiver who inspires the NET community with passionate involvement. The awardee embodies the passion, dedication, and leadership and the spirit which Monica Warner assisted patients, caregivers, and families affected by NETs. If any of you, and I know many of you have had the pleasure of knowing Lisa, you know that she embodies all of this and more. This award comes with a $10,000 donation from AAA to a patient-focused charitable organization, which Lisa has graciously requested to be given to LACNETS. Our LACNETS family and the larger NET community are so incredibly proud of Lisa and grateful to her for all she has done. Congratulations, Lisa, on winning the Monica Warner Award this year.
Thank you, Mary, and thank you all of you. You're going to make me cry. So I'm going to show you the award, and this is such an honor, and it's especially meaningful to me since 2020 was a year of transition, not just because of the pandemic, but really especially after the loss of our dear friend and founder, Giovanna Joyce Mbesi. I take very seriously my promise to her to carry on her torch, as I know many others do as well. And I know Giovanna would be so proud of what we've been able to accomplish together. So thank you all for being part of this community and for helping carry on this torch. Thank you so much. So now we're excited to introduce our final set of speakers. Dr. Henderfer, take it away.
Yeah, very honored to present Dr. Pamela Coons, Chief of GI Oncology at Yale University. Her talk is titled NET Research, What's on the Horizon?
Thank you, Dr. Henderfer. And I'm excited to introduce NET caregiver Gilda. She is inspiring because of how she's walked alongside her husband. And for our Spanish-speaking audience, Gilda's story, along with her husband's story, which was broadcasted earlier, along with the presentations by Dr. Suarez, Dr. Del Rivera, and Dr. Duma, are also available to view in Spanish on our website, lacnets.org/Spanish resources.
And I am very happy to introduce our dear friend, as well as colleague, Josh Mailman, who many of you know. Obviously, Josh has played an integral part in the patient advocacy community and runs the NorCal CarciNet group as well. In addition to that, he advocates on behalf of all NET patients in the role of clinical trials in the NCI as well. So really a big part of our community, and honored to introduce him. And he'll be talking about patient advocacy and support.
Hi, my name is Pamela Coons, and I'm an associate professor of medicine in the Division of Oncology at Yale School of Medicine. It is my great pleasure to speak to you today about NET research, what's on the horizon. These are my disclosures. And I will give, over the course of this 15-minute talk, a brief outline of clinical trial facts, the life cycle of a clinical trial from lab to FDA approval. We will talk about some new NET treatments that will hopefully not have been covered in earlier talks, and then how you can find a clinical trial. I'd like to start with this timeline of recent advances, not to go through each of these, but really just to highlight the fact that we've had an explosion of new discoveries over the last decade, since 2011, and all of these had to go through the clinical trial process. So I want you to keep that in mind, that both the imaging modalities up on the top and the treatments on the bottom had to go through this clinical trial process and FDA approval, and we'll speak about that a little bit. So why are clinical trials so important? They are really a key research tool for advancing medical knowledge and patient care. And clinical research is done to learn two things: whether a new approach is safe and effective, and which treatments or strategies work best for certain illnesses or groups of people. Yet only 8% of US adults with cancer participate in clinical trials. And there are, of course, many barriers to those, but I hope to really explain clinical trials today and debunk some of the myths. So let's talk first about some facts about clinical trials. So clinical trials are not necessarily proven to be better than standard treatments. So I think we have a lot of hope about clinical trials, and I think that's valid. But if you are weighing options between a standard therapy and clinical trials, that's a conversation to have with your oncologist. Clinical trials are not just for patients without other options. In fact, we'll talk a little bit about a clinical trial that is given in the postoperative setting. So there are clinical trials for many different settings of disease. And you will not unknowingly get a sugar pill or placebo. I think that's a fear of a lot of patients. We, as clinical trialists and as doctors offering clinical trials, go over whether or not a placebo is involved in a clinical trial. You will be told what your sort of risk is of being randomized to that placebo, but that's explained in the course of an informed consent. If you decide to participate, you can change your mind later, and you cannot directly compare one results of a trial to another. And then lastly, some standard of care costs may still apply. So visit copays, some labs, if they're considered part of standard of care, they may go through your regular insurance. So let's talk just briefly on phases of clinical trials. So first, there are preclinical studies. These are determining if they work in mouse tumors or in test tubes. Phase 1 trials test safety. This is often any type of tumor eligible, and usually 15 to 25 patients. A small study determines side effects and the best dose. Phase 2 trials are a preliminary test of efficacy. So early hints at, is this drug or combination of drugs effective? It's usually limited to a specific tumor type, also a fairly small study. And then the phase 3 studies are those that are definitive, usually test efficacy compared to a standard treatment, is limited to a specific tumor type like a neuroendocrine tumor. Sometimes there is a placebo. These are often much larger, 200 to 500 patients, and is essential to assess survival differences. And it's usually comparing one treatment to another. And then phase 4 is often one we even forget about, but this tests long-term safety after FDA approval. I'd like to next talk about sponsors for clinical trials, i.e. who pays for these studies. And as someone who leads a large clinical trial portfolio, I try to have all 3 of these different types of sponsored trials in my portfolio. As a patient, it impacts you less, but I think it's still useful for you to know about the sponsors. So they are investigator-initiated, industry-initiated, and National Clinical Trials Network. The investigator-initiated studies are often smaller, usually available only at a single institution. The idea is initiated by an academic doctor, and the funding could be from that institution, philanthropy, and/or a pharmaceutical company. Industry-initiated trials could be phase 1, 2, or 3, involves many sites, sometimes international. The idea is initiated by that company, and the funding comes from that company. National Clinical Trial Network trials are also all phases, sponsored by the National Cancer Institute, open at centers participating in a National Clinical Trial Network group. So for example, ECOG Akron, SWOG Alliance, and that funding is federal. The clinical trial regulatory pathway, I think, is worth going over. It's a long road to bring a drug from basic research to FDA approval. It takes about 10 years to go through this entire process. So I want you to think about this as a funnel. So that green funnel in the middle are the potential new medicines. They go through basic research, drug discovery, preclinical studies, meaning in mice or in the test tube. And then an investigational new drug application is submitted to the FDA to begin the clinical trial work. The clinical trials, as you've just learned, happen sequentially. Each drug has to go through each of those phases. So remember, safety is determined, then preliminary effectiveness, and then a pivotal RCT or randomized controlled trial. And as you can see, that funnel is slowly narrowing. So if a drug is deemed unsafe, it may not move from phase 1 to phase 2. And if at the phase 2 point it's deemed ineffective, it won't move to phase 3. Then, if it passes all of those steps, then a new drug application is submitted. The FDA reviews that, and then it can finally achieve FDA approval, and then it moves into that post-approval research and monitoring. So when a phase 3 trial is completed and that new drug application is submitted to the FDA, they take into consideration data from all of those different sources, preclinical, phase 1, phase 2, and phase 3. They look at proposed labeling. That means what's the indication for treatment? So what stage of disease? Is it after surgery or is it for patients with metastatic disease? They look at safety, patent information, IRB compliance information, and directions for use. The FDA review team then checks for completeness. They have 6 to 10 months to make a decision. That timeline is called the Prescription Drug Use Free Act, or PDUFA date. And there is a review by a group of team members. And if approved, the FDA assists with refining the indications. And then post-market safety monitoring continues for many months. So if we think about what we currently have available for NET patients, each one of these has gone through that entire lengthy process. So we had pancreas and small bowel NET. This is for lung NET. These algorithms are adopted from the National Comprehensive Cancer Network algorithm that many physicians use to determine what are the appropriate algorithms for treatment. I'd like to bring up a drug that is not on this list, but has actually been through phase 3 trials. It's called surufatinib. I'll remind you that anything that ends in an IB is a tyrosine kinase inhibitor. So we already have sunitinib or Sutent approved for pancreatic NETs. So surufatinib has been studied in 2 large phase 3 trials in China. So SANET-P, which was a phase 3 study of 172 patients with advanced well-differentiated pancreatic NETs, were randomized to receive surufatinib or placebo. And the take home from this slide, if you can see on these curves, the surufatinib arm is in blue and the placebo arm is in red. Separation of the curves is good. So on the left is the time it took for patients to have progression, so progression-free survival. And the figure on the right is overall survival. So with that blue line on top and a separation of the curves, that shows that there's benefit from the surufatinib. So specifically, surufatinib had a 10.9 month median progression-free survival compared to 3.7 months for placebo. The response rate or shrinkage rate was 19% for surufatinib versus placebo. Common adverse events or side effects were high blood pressure, protein in the urine, high triglycerides in the blood, and some diarrhea. I want to make another key take-home point from this is that the little target that you see in the top right corner, those indicate what targets this drug hits. And this has a unique angioimmune mechanism. So it targets both the immune system and the blood vessel system, or the vascular endothelial growth factor. The second phase 3 study was in extrapancreatic NETs. And this was also conducted in China. The progression-free survival and overall survival were both longer for surufatinib. The response rate was a little bit lower for extrapancreatic NETs, so that shrinkage rate 10% versus 0%, and the side effects were about the same. So this was for extrapancreatic NETs. Serafatinib was approved by China's National Medical Products Administration, that's the equivalent of their FDA, in December of 2020. So what's happening in the US? Well, a phase 1/2 study was conducted in the United States very recently. So this means they tested safety and early efficacy in 32 patients with NETs. There were no new safety signals. We also saw a 19% response rate in pancreatic NETs, no shrinkage in extrapancreatic NETs, but that disease control rate, ability to slow down the growth, was 100% in those 32 patients. So it meant that it was effective at slowing down the growth of these cancers. The median progression-free survival was not yet available. So what this company then did is they went to the United States FDA. They have submitted a new drug application on the basis of the phase 3 trials conducted in China and the phase 1/2 studies conducted in the United States. So that submission has just been completed a couple of weeks ago. So I mentioned this novel angioimmune mechanism. I think this is really unique to this drug. This is different than sunitinib. The CSF signaling pathway, that's colony stimulating factor, is one of the unique mechanisms, and it promotes infiltration of something called tumor-associated macrophages, which is part of the immune system. And that combination and targeting the blood vessel system may help it be uniquely effective. So some tips on tyrosine kinase inhibitors, that serafatinib is part of this class, including sunitinib. And I think that they have some unique side effects that are worth mentioning: diarrhea, nausea, fatigue, vomiting, hand-foot syndrome, and high blood pressure. And the most common grade 3/4 adverse events are low neutrophils and high blood pressure. And we can do some dose reductions to help make these more tolerable. And I think it's really critical that we partner with specialists. And I have some examples here on the right of partnering with gastroenterologists, cardio-oncology, or cardiologists who specialize in heart side effects from some of these medications. Dermato-oncology is also a new specialty to help deal with skin side effects of some of these medications as well. I'd like to just briefly mention the National Clinical Trials Network. There are 6, as you can see here, National Clinical Trial Network groups. They all work collaboratively. And I bring this up because we actually just had a National Cancer Institute neuroendocrine tumor clinical trial planning meeting led by myself, Dr. Simran Singh, who's a medical oncologist in Canada, and Dr. Tom Hope, who's a nuclear medicine specialist in Northern California at UCSF. And this clinical trial planning meeting was entitled Treatment in the Era of PRRT. It was held in March, and its purpose was to help us think about the next generation of clinical trials, given that PRRT has really changed the landscape, with the goals of evaluating potential strategies for enhancing the efficacy of PRRT, developing clinical trials that capitalize on the stress cooperative network, and developing trial designs to evaluate the optimal sequence and timing of PRRT in GEP-NET relative to other therapies. I'd like to spend the last few minutes going over key NET clinical trials to leave you with some hope about the future for NET research. There are a number of trials here. It's a bit of a busy slide, and I'll take you through these step by step. So the first row is a large national clinical trial network, or the NCTN clinical trial, that's in well-differentiated pancreatic NET and GI and lung NET. It's called the CABINET study. It's been open for a little while. It's cabozantinib versus placebo. So this is another one of those tyrosine kinase inhibitors. It's a large study, and we have about a quarter of the patients accrued already. We have a new clinical trial, the next row, for paraganglioma and pheochromocytoma. That's temozolomide plus or minus olaparib, which is a PARP inhibitor. The next row is the RET-NET study. This is a study looking at bland embolization versus lapiodal embolization. So looking at different forms of liver embolization for patients with NETs. The NETTER-2 clinical trial is a first-line trial of Lutathera, or 177 ludotate, and in a slightly higher Ki-67, so grade 2 and grade 3 up to Ki-67 of 55%. And then the COMPETE trial looks at grade 1 and 2 GEP-NETs and is a randomized study of 177 Lu edotriotide, which is similar to ludotate, versus everolimus. So all of these are currently open and accruing. This next list are soon to open studies, and we're really excited. These all are coming out of the National Clinical Trial Network, and they really represent new studies in diseases that have not been studied before. So the first is in LungNet, so it's a ludotatate versus everolimus study. The second study is looking at extrapulmonary, so outside the lungs, small cell neuroendocrine carcinomas. In that third row is our first adjuvant study, so looking at patients who've had a pancreatic neuroendocrine tumor surgically removed and giving them CAPE-TEM versus observation. And then that fourth row is in well-differentiated grade 1 through 3 pancreatic NET and comparing ludotatate versus CAPE-TEM. So all really practical, important questions in the field. So how can you learn about clinical trials? I would say the first point is your oncologist and a NET specialist should be your primary guide. So ask them about what clinical trials they may have available locally and certainly in your geographic region. Your institution and cancer center websites are also a great resource. I've listed some local to LA. I do know that patients will be watching who don't live in LA, but these are just some examples. And they often have search fields where you can put in the name of your disease and specific criteria to see if there are clinical trials that might be suited for you. The clinicaltrials.gov website, I will caution, is a bit cumbersome to use, but there are some features where you can, again, select specific diseases and select which studies are open. I'll give you an example here that I did a search and found close to, I think, 600 studies that are open for neuroendocrine tumors and actively recruiting. So take-home points I want to leave you with are that we've made many advances in the last 10 years in terms of treatment and imaging. All of these are due to successful clinical trials and to patients who were willing to enroll on them and our clinical trial researchers and clinical trial coordinators and these huge teams that can make this happen. Clinical trials are critical to make progress in NET treatment, and I think really are reason to be hopeful. I envision the next decade of clinical trials to involve novel forms of PRRT, ways to make PRRT more effective and safe, immunotherapy, and personalized therapies. And I think these will all be incorporated in future trials. And I'd like to thank patients who are listening who have been clinical trial participants. And I think if you are personally interested in clinical trials, I really encourage you to learn more and ask your treating team about them. So thank you so much for allowing me to speak to you today about this topic, and I look forward to the panel discussion.
Hello, my name is Gilda. From the moment we learned that my husband Federico had cancer and they gave us the terrible first diagnosis, no more than 2 months of life without the possibility of surgery or treatment, I thought, this is not going to be like that. This time we will win. Because less than a year before, I had lost my only brother to brain cancer. My brother was taking care of our mother, who was 90 years old at that time, and she had been left alone in Argentina. From here, I support my family as much as possible, contacting doctors and people who help them through the terrible process. But I could not save my brothers. The only family we have in Los Angeles are our 2 children and our grandson. At that time, only one, Herman, lived in Los Angeles with his son, Nico, and Gustavo lived in Baltimore, Maryland, but he decided to move to California to be close to us. Also, luckily, a very good friend, past president of the American Pancreatic Association, and at that moment doing research on pancreatic cancer at the Mayo Clinic in Rochester, Minnesota, was with us from the first moment. At that time, my husband and I were doing basic hearing research at the House Ear Institute in Los Angeles, and the doctors there were also very helpful. I was very lucky to have my children, a good friend who knew a lot about the disease, and people from the medical environment close to me at this very difficult time. They made it easier to me to make decisions, and with a super positive attitude of all of them, we moved forward. In a scientific lecture, I found information about two groups associated with the SIN-MAN UCLA Center, the Mindfulness Meditation Group and the Circle of Reflection Group. The Mindfulness Meditation Group was integrated for cancer patients, and I was the only caregiver at that moment. However, it was very important for me to be part of this group because listening to the people who had problems similar to my husband helped me understand him more. And the most important thing was to know that I have a place every week where I could talk about my concerns and emotions. The Circle of Reflection Group consists of patients and caregivers, and it was more spiritual. It was a place where I felt very protected. In this group, I met Giovanna. Giovanna, like my husband, had a net. She told me about LACNET. From then on, I started to learn about LACNET and to attend a different talks organized by them. And later, I was part of the Wednesday support group and the Saturday caregiver groups. The LACNET group of Wednesday is super instructive about new treatment, different specialists, diets, etc. The LACNET caregiver group is a new group where we all speak from the same corner. Very transparent people with the same problems, fears, situation, and that by being able to share them, we feel relief and protected. Also, Lisa told me about the coaching program. I was so lucky to be able to participate in this program, and it was very supportive to me. It was very well organized, and it gave me the help that I need at that time. I went back to having different projects, and with the help of Julie, my coaching, and finished them. I am very thankful that at the end I had a very nice relationship with Julie. I sincerely recommend to the LACNET people use this LACNET coaching program. I want to say thank you to the LACNET for giving me and my husband Federico the opportunity to tell you a part of our history.
Hi, I'm Josh Mailman. I'm here to speak to you today on patient advocacy, and really the big question is, how you can help. And so we want to talk a little bit about patient advocacy today and some of the things that LACNETS has done, NorCal CarciNet has done, and many members of our community have done as well. I'm the president of NorCal CarciNet, but more importantly, we all are patients first. And that's really important when you get into patient advocacy, to understand that your health comes first and take care of yourself, because we all have stories. And actually, part of being in patient advocacy or doing patient advocacy is being able to tell your story. And I'll talk about that in a second. But my patient story is, pretty easy or very straightforward. I was a blind pickup in 2007. Not like other people in this group. I did not have any symptoms going into this. I attended my first conference after joining a support group in Toronto in 2008. And that actually led me on a kind of a whirlwind travel to go to Germany for therapy and also for my first gallium-68 scan in 2008 as well. while I was doing well, I asked my oncologist this really simple question: how can I help? And that led me down this path of advocacy. So actually, what exactly is patient advocacy? Because it's different depending on who you talk to or the context that you're in. So just a quick thing, if you look in most places, this is it's really one phrase that has many hats. It's an area of specialization in healthcare, and this is probably more of a technical term. It can help patients navigate through healthcare systems. It can be something where you're getting help with your doctor directly. Activities could also be things like patient rights, matters of privacy, confidential, informed consent. I bolded awareness building, support, and education of patients, survivors, and their carers, because that's something actually we do pretty well in the NET community, and I'll talk about that again. But really what patient advocates do is they give a voice to the patients, to the public, and to political and regulatory worlds. And that's what I'm going to talk about, and how you can contribute to the advocacy world and to giving a voice to our disease and to patients everywhere. So how does the NET community stack up when we try to look at this? Now, as I said, in that earlier definition, there's so many ways you can describe advocacies. It can be individually on the patient level of supporting a patient, being a patient advocate or navigator in one way. It can also look at how we will deal with research, how we deal in the world of politics or fundraising or even watchdog. And so what we do well in the NET community, obviously you're here today at an education conference, and there are LACNETS puts on things every month. Carcinoid Foundation puts on things every week. We do really well in the NET community in the support and education of patients. We do a little less well in the education of survivors and their carers, although LACNETS and my group, NorCal Carcinet, have separate caregiver groups as well. We do pretty well in awareness building. I didn't completely bold that out because we're really do build awareness with either our zebra logos or other things that we do, but we don't seem to get a very broad audience. What we might need work on, I put fundraising. We do good jobs in fundraising for some of the foundations, but we need to work to figure out how we're going to spread this around across the multiple entities that need fundraising. Patients' rights, we don't as a NET community do much in patients' rights or matters of privacy and working on informed consent and patient representation in various different areas, regulatory bodies, and we'll talk about that as well. Where I've spent my time personally in advocacy in the support awareness fundraising area, I'm the president of NorCal Carcinet community, and we offer support and education as well. I also work with the Society of Nuclear Medicine and Molecular Imaging. I was the chair of patient advocacy, as well as their working group, which will for Gallium-68, which we'll talk about. I'm a board member of NetRF, where I've also worked on fundraising at large for the community. In research, I work with many nuclear medicine docs in Warmth, which works on molecular therapy. Was on the NCI task force for NETs. I'm now on the steering committee for patient advocacy and the steering committee for all GI cancers. I'm an FDA patient rep. I've worked with on the research committee in many different areas, and recently I'm the patient PI of the PCORI-CERNET study, and we'll talk a little bit about PCORI as well. In May 2021, I'm happy to announce that I was appointed to a 4-year term as a patient's rights committee to the Nuclear Regulatory Commission Advisory Committee on the Medical Use of Isotopes. So this is another area where I'm contributing in patient advocacy. So research, and I want to talk about this a little bit, research and policy advocacy is different. We're really aware of the education and support advocacy that we do and LACNETS does as part of NorCal Carcinet and LACNETS, but research and policy advocacy is different. But the really good thing is there are classes for this because you have to follow what's going on in the medical literature on your disease and perhaps over many other diseases as well. Luckily, there's a class for this. There are many classes, as a matter of fact, because we've been working with patient advocacy now with things like the National Cancer Institute for nearly 30 years. And I have a couple of different areas where you can get ideas on how to educate yourself if you're interested in research and policy. But I also, one of the books I give to many new patient advocacies in the research area is something called When Science Offers Salvation by Rebecca Dresser. It's a great book that tells you, really understands your roles and responsibilities as a patient advocate. It's not to cure yourself, but to understand how your role as a patient advocate can help work to cure others and to make sure that the best science is being done for your disease or condition. And yes, there's a lot of study behind this. As a matter of fact, PCORI, which is the Patient-Centered Outcome Research Institute, spends $320 million or more a year in research. That was the 2016 number. And the really great thing about all of this is they actually put all of their data online. And so this is just all the citations or all the research that they funded. You can see over 1,000 different studies that they've actually done that have been patient-led or patient-involved studies for diseases. There's actually plenty of areas to engage across the continuum of drug development, from the FDA, which has an entire website dedicated to patient engagement at the FDA, to looking at different things that you can do between Europe and the FDA as well. So the good news is there's a rich history of patient engagement to learn and build upon. We are different. NETs are different than other diseases. So our voice is really important if we're to get our what's needed for NETs through design and development or get funded. We do have willing partners. You can work with your local institutions that may have things for NET cancer, or they may have things that help in the general hospitals. They're the clinical trial groups. We call them the cooperative, like SWOG or other things like that, where they're looking for patient representation and understanding how patients will work with clinical trials. Often the pharmaceutical companies are looking for volunteers, not just for clinical trials, but to guide them as to what would make a good trial. We work with medical societies all over the place and regulatory and government agencies, as I spoke about, with either the Regulatory Commission, congressional agencies, other things that you can do at the state level as well. We also need to support our researchers with dollars and time, because we have things that are happening that may just detract our researchers from working on NETs. We need to make sure that we're putting up money to keep people interested and involved in NETs. So we can lead to better outcomes. It can take time, but you need to be diligent in what you're doing. Your activity may not lead to something right away, but it may lead to things down the line. One of the things I'd love to talk about here is this is one of the ways that advocacy can work. This was work that was generated from a meeting that Giovanna and I attended back in 2017 in San Diego regarding better patient-doctor communication. And Giovanna and the LACNETS crew ran with that and created this great tool in partnership with City of Hope and Dr. Dan Lee, who's been here today, and created this great tool called Net Vitals. And you can see it was an accepted abstract in the 2020 eNets conference. This was released in 2018, I believe. And again, this is a great example of where patients can notice something, create something, and now it is a tool that is used by clinicians as well. We can make an impact. I talked a little bit about Net Vitals there, but these are some of the things that we've worked on in NorCal CarciNet. We've worked on in 2015 with the FDA getting the Gallium-68 DOTA trials expanded when there weren't very many. We've done things with the Nuclear Regulatory Commission when they were going to take Germanium-68 out of production to make sure there was adequate supply. Just recently, members of all of our groups worked on writing letters to Humana when they were going to cut coverage of PET-CT coverage for patients, not only NET patients, but all patients. And that was able to be reversed, which is fantastic. And you can advocate beyond NETS. This is a picture of the ASCO ACT network. And they're working right now. You just put in your zip code and you can see what types of things that are generally available for cancer. This is expanding telehealth, which we've all grown to appreciate, but it's really something that we might lose not only in the NET community, but all over as we exit this pandemic at some point. We may lose our flexibility in telehealth. And here is ASCO looking for help in advocating on behalf of these things. And there's several different aspects that we can take a look at as well. Not sure where to start? Well, we've got a couple really great examples right here. We have LACNETS, which could always use your help, your time, your dollars, or your local support organizations. We have national organizations as well that can use your help or your contributions. We have research policy and patient rights. The cooperative groups that I said are always looking. There was recently a call out for rare disease advocates for SWOG, which many of our members in NorCal Carsonet applied for. So there's these cooperative groups, these research centers in your local area as well. You can join our mailing list. I have it right here that will help you find, when we find new things that NET patients can get involved in, we send letters to our advocates to help advocate on behalf of these things. So I want to take a moment to thank you all for listening to this. And remember, you can sign up to be part of our advocate list just by going to bit.ly/netadvocate. And I hope you enjoy the rest of the conference and look forward to the Q&A.
Wow, thank you so much, Dr. Kuntz, Gilda, and Josh. We are now going to be taking a 15-minute break to give all of our participants time to visit with the virtual sponsor booths. Each of the participating pharma companies have their own virtual sponsor page found on the LACNETS conference page, www.lacnets.org/2021. This year, the first 100 participants to visit and confirm their visit at each sponsor page will receive a $10 Starbucks gift card sent to them via email. To confirm your visit on each of the 5 sponsor pages, just scroll down to the bottom of each dedicated sponsor page to find the Confirm Your Visit form. This is where you will type in your name and email address to confirm your visit. Be sure to do this on all 5 sponsor pages to receive your gift card. Now, Lisa, can you remind our viewers about the upcoming live Q&A and how to submit their questions?
Thank you, Lindsay. Again, we will have our live Q&A in 15 minutes. Submit your non-case specific questions at slido.com and enter the event code LACNETS 2021. And just a reminder again that our programs are intended for educational purposes only and do not substitute for medical advice. Talk to your own medical team if you have any questions or concern about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. We will see you in 15 minutes. We're very fortunate to have this incredible panel of NET experts join us from across the country today. All of our speakers are deeply committed to the NET community and are active in national NET organizations, NET research, and of course, they see and treat NET patients as well. So it's an honor for me to introduce again our speakers for today. Dr. Heloisa Suarez, medical oncologist from Hudson Cancer Institute, Dr. Kalicia Clark, surgical oncologist from Medical College of Wisconsin, Dr. Thor Hofdunarson, medical oncologist from the Mayo Clinic, Dr. Thomas Hope, radiologist and nuclear medicine physician from UC San Francisco, Dr. Charles Nutting from the Endovascular Consultants of Colorado, Dr. Heidi Del Riviero, endocrinologist and medical oncologist from the NIH, and Dr. Pamela Kuntz, medical oncologist from the Yale Cancer Center, as well as Josh Mailman, president of NorCal CarciNet and patient advocate extraordinaire. Josh will be serving as co-moderator for today's Q&A. Unfortunately, Dr. Duma was not able to join us for today. And the Q&A will be divided into two parts. I will be moderating the first part with Dr. Suarez, Dr. Clark, Hofdunarson, and Dr. Kuntz. And then Josh Mailman will moderate the second part with Drs. Hope, Nutting, Del Riviera, and Dr. Duma. We will be trying to cover as many questions as possible, but of course, given the number of questions, we cannot get to all the questions since there are simply too many questions. We've had about 70 questions come in so far. And again, just as a reminder that our programs are intended for educational purposes only and do not substitute for medical advice. Talk to your own medical team if you have any questions or concerns about your individual treatment or care. And we all have our own opinions, and these are our opinions only. They do not necessarily represent the opinions of LACNETS. So with that, we will first start with the first group of panelists and the second group. You're welcome to turn off your cameras. And let's start with the first question. Does NET cancer frequency, describe NET cancer frequency compared to the breast, 1 in 8. And this question will be for you, Dr. Hofdunarson. Describe NET cancer frequency compared to breast, 1 in 8. Review NET cancer incidence, prevalence, and translate this from X in 100,000 to 1 in question. So, Dr. Hofdunarson, take it away.
I will try to do my best. I am not really good at math, so I will will warn you. So just to give you an idea about the comparison between breast cancer and neuroendocrine tumors. So in the US, you're obviously looking at, in terms of breast cancer, overwhelmingly female population, but we're looking at almost 300,000 new cases of breast cancer among women in the US per year. We're looking at 23,000 new neuroendocrine tumor cases across the US over a year. So you see that, and that's both for men and women. So you see that there is a vast difference there. If we put it into a perspective, and for me, I sometimes explain this, living in Rochester, Minnesota, which is a town of about 100,000 people, that equals about 7 new cases in Rochester per year of all neuroendocrine tumors of all origins and grades. So it's not very common, but it's not very rare either. So, but just because many patients with NETs live for a long time, the prevalence, so the number of people actually living at any given time with the disease is actually very high. So it's we add relatively few new patients to the pool every year, but there's a lot of people with active NETs out there at any given time because thankfully survival is very favorable compared to other cancers. So hopefully that explained it, and I can go into some more details.
Thank you, Dr. Hofdunarson. That was helpful. And I just want to check to see if any of the other panelists have anything else to add to that. Okay. If not, then moving on to another question about causes, which is very common and, of course, understandably a concern for the NET patient community. Does chronic stress cause cancer? And let's ask Dr. Suarez if you might address this. Does chronic stress cause cancer?
That's a very interesting question. I don't think we have clear documentation because a study like that will be very hard to do. But at the same time, there have been studies done, particularly I think in mice, that show that animals that have been on continuous stress had developed alterations in their systems that led to several illnesses, including potentially cancer in the mice. So right now in humans, we don't have that confirmation,
But I think someone that lives on years of stress because of potentially all the hormones, that could be something that might develop in the future. Again, this is completely just my thought, and I would love to hear from my colleagues. And we don't have any clinical trials to validate that.
Dr. Hafdonison, Kuntz, or Dr. Clark, if you have anything else to add?
You know, I get that question a lot as well, and I try to deflect a little bit, and because we really don't know that it causes cancers, but we do have at least some anecdotal evidence that it affects the way that people sometimes respond to treatments and respond to surgery. So we spend a lot of time sort of focusing on stressors that we can try to control or minimize. Especially, I'm particularly interested in that period between diagnosis and surgery. So in cases where we're doing a neoadjuvant approach, where patients have the anxiety of waiting for the surgery and they think surgery is a big moment. I think stress during that period can certainly impact the way that you respond to treatments, but also how you recover from surgery. So we actually try to integrate a clinical psychologist that's able to help minimize stressors with behavioral changes, focus on small things that are actually seemingly big things like insomnia, anxiety, especially during that neoadjuvant treatment and the immediate postoperative treatment, because I definitely think that there's a link there.
Thank you for that. And that's really encouraging to hear that, yeah, even, you know, from a surgical standpoint, you're thinking of the whole person and the whole health. Thank you. Dr. Kuntz, there's a timely question that came up, of course, about COVID. It's not surprising. Neuroendocrine cancer and COVID, I'm sure you get this a lot. Are we at greater morbidity risk? And is there any consideration for therapies and vaccination timing?
That's a great question, and yes, timely. I mean, I think that broadly, we know that patients with cancer do have increased risk for serious outcomes from COVID. I think that, there's probably a huge range depending on whether patients are on treatment, have recently had a big surgery, where they are in the course of their journey. So I think there are a lot of caveats to that. And there have not been large studies looking at patients with neuroendocrine tumors. I get asked frequently also about the safety of the COVID vaccine and the efficacy of the COVID vaccine in the NET patient population. And I think that broadly, our American Society of Clinical Oncology has come out with a statement saying that patients with cancer should definitely get the COVID vaccine. We think that it's effective. There are specific patient populations that it may be less effective, and those are patients going through bone marrow transplants and patients who are receiving a very specific type of immunotherapy called CAR T cells. I'd welcome other input from my co-panelists.
Dr. Hafdonison or Suarez?
So I can speak to it a little bit. So we are just about to publish a large international registry on neuroendocrine tumor patients with COVID. So sort of joining forces with investigators in Italy and Spain. And there is definitely increased mortality, but not as high as seen in the early studies of cancer patients in general. With COVID, probably to some extent reflecting that many of the neuroendocrine tumor patients are not on very aggressive immunosuppressive therapy. But otherwise, I have not much to add to what Dr. Kuntz said.
Thank you for that.
We do try to separate the administration of the COVID vaccine from surgery. Surgery in itself can sometimes be somewhat of an immunosuppressant state. And we do have evidence for prior vaccinations that delaying the initial inoculation from surgery a few weeks can actually potentially increase the immune response. So right now at our institution, we try to wait 3 to 4 weeks after major abdominal surgery to then administer the first dose of the vaccine.
Thank you. And that's helpful to know because as you know, patients are still undergoing surgery at this time. I know, Dr. Clark, you mentioned in your talk about some morbidity, and there was a recent paper that came out, and I'm going to direct this first at Dr. Hafdonison, because I saw you tweet about Dr. Hallett's paper that was recently published. If you might comment on, well, the question is, could the presenter summarize the recent paper that was published by the authors in Toronto about specific prognosis. And if you might comment on what that paper was and give a little summary.
So I can, as I brought this onto myself by tweeting. So this is a really nice study that's coming out in one of the scientific journals, looking at the prognosis or life expectancy of patients with neuroendocrine tumors using a very large Canadian data set of about almost 10,000 patients. And what they found is that in patients with the metastatic neuroendocrine tumors, they are certainly at much higher risk of dying of metastatic disease than from other things. But on the other side, the patients with the stomach, colon, rectal, and I believe pancreatic neuroendocrine tumors, if diagnosed with localized disease and if they had appropriate surgery, their risk of dying of other causes than neuroendocrine tumors is actually higher than dying of recurrent neuroendocrine tumors. And I will say that this is in line with a similar study that we just actually published this year using a US data set of almost 100,000 patients, but we didn't go into all the same details as the Canadian team did. So what I'm saying here is that for early stage resected, low grade, grade 1, grade 2 neuroendocrine tumors, the long-term prognosis is actually very, very good.
Thank you for that. And just for the sake of time, because we have so many more questions, I'm going to move along to workup and some of the workup that's required for this disease. And Dr. Suarez, let's go to you. Do you recommend EGD and colonoscopy for all initial NET workups?
Not necessarily. If I have good imaging that already tells me where the primary tumor probably is, for managing the patient, I will not necessarily do it, especially if we feel that's in the small bowel. Chances are that we're not going to reach the small bowel. So I would say probably in my practice, the minority of the patients I'll have to recommend it, just because we're doing so much better in terms of imaging. Having said that, I think in general, particularly for patients that are young and overall are healthy, where we feel that these patients will do well for very, very many years to come, I think they should continue to have all the appropriate screenings for their age, just plugging this extra additional information there.
Thank you. And I wanted to see if any of the other panelists have anything else to add to that.
I just wanted to echo what Dr. Suarez says. I probably diagnose at least 2 colon cancers a year from just recommending screening colonoscopies in patients that are seeing me for a completely different cancer type. And most recently, this was actually a neuroendocrine patient of mine that had a small bowel neuroendocrine tumor. And I remember she was so upset with me because she just wanted to have surgery. And I thought, you know what, we really need to get this colonoscopy. And we did find a transverse colon cancer that would not have been resected in her surgical specimen and would have been left behind had we not known that going in. So we just saw each other last week, and she joked about her free surgery, because it sort of was. It was something that we would not have been able to predict, and eventually perhaps we would have found that tumor, but again, it would have been a second surgery, more morbidity, and potentially more advanced disease at the time of presentation. So I do agree that I encourage patients that are seeing me, if they have not undergone their routine screenings, especially for colonoscopy and colon cancer, I do recommend that. But outside of that, if I have good imaging about the location, I don't typically recommend it.
Thank you for that. That's very helpful. Dr. Kuhns, let's start with you with this question. Please speak to NETs with unknown origin. I'm sure you get this a lot also. How does not knowing the origin of the well-defined grade 1 metastatic NETs affect diagnosis, treatment, and survivability?
Happy to address that. First of all, I think that that's becoming less and less common now with our better imaging. And I think especially with our somatostatin receptor-based imaging, like Gallium-68 dodaped or copper-64, I think we're having better luck finding the primary tumors than previously. But this is still a clinical challenge when this does in fact happen. We still have therapies that we can offer to these patients that we think may be applicable to a number of different NET primary sites. somatostatin analogs, everolimus, ludotatate. These are examples. But I will say that our clinical trials, as I spoke to in my talk, are really nowadays being directed at studying specific primary sites. And so it does help us tailor the treatment if we know the primary site in advance.
Thank you for that. And just want to see if any of the other panelists have anything else to add to that.
Lisa, I had one more thought, and maybe I'll actually ask Dr. Clark. You know, knowing the primary site's actually really helpful as we think about some surgical planning. I'd say especially for small bowel nets. I wondered if Dr. Clark could speak to that.
So absolutely, I think this issue has gotten a lot simpler with better imaging, and so very rarely now do we actually operate without having a fairly good idea about where the primary tumor is. In the setting of small bowel neuroendocrine tumors, however, these primaries can be so small it's often missed on cross-sectional imaging. And one of the frustrating things is sometimes that ends up resulting in a significant delay in sort of surgical treatment. And I'll tell you that if you can see a lymph node within the mesentery, that it's almost always going to be a small bowel met. And rather than trying to get additional imaging or capsule endoscopies, et cetera, I think the place that those patients really need to be is in the operating room, because we can almost always find those primary tumors on palpation or direct examination of the bowel. It doesn't even mandate an open operation. We can still do this laparoscopically with either a small incision for a hand port to basically manipulate the entire bowel. But if you can see a large lymph node in the mesentery, we can almost always find that primary tumor.
Mm-hmm. Thank you for that. And speaking of, getting in there and finding the tumor and taking a look at that, Dr. Suarez, I was wondering, there's a simple question about how do you get the tissue to test for the Ki-67?
That will be a biopsy that can be, if we have a surgical path, obviously, if the surgery, the tumor was removed, then the pathologist will pick up, will slice the tumor, and then use a special staining to look for that and grade how many of the cells are positive for that in regards to the rest. And then if you don't have a full sample of the tumor, just a biopsy of let's say a metastatic site of the primary the pathology can do the same. I have to say, and I would love to pick my colleagues' brain on that, there is a lot of variability within the tumor, what's the Ki-67. And I don't know how much you discuss that with your patients, particularly if you have a sample or you have a large tumor and you have different Ki-67s that were done, and then the patient asks you. So, but yeah, you calculate that using the tissue that you have.
Dr. Halfdanison, Coons, or Dr. Clark, do you have anything else to add to this?
So I would echo what Dr. Suarez said about the what we call the heterogeneity of the Ki-67 within the tumor. So keep in mind, we're only testing a minuscule sample of the tumor, so that does not necessarily reflect the entire tumor. So what I tend to do, I have a low threshold for repeating a biopsy. Let's say if there is a liver lesion that's growing out of sync with some of the other lesions, especially for pancreatic neurotumors. I've been surprised so many times with what I call sort of a grade, tumor grade sliding or tumor grade shifting into a grade 3 that may actually call for different methods for treating.
And I'll just say we're actually publishing this paper right now. I think it's under review, but the accuracy of FNA Ki-67 estimation within the same lesion is actually really good, at least at our institution. And I think that the caveat is that we have a pathologist who's present at the time of the FNA biopsy, and they sort of determine adequacy of the tissue sample. And so along with the technician that's performing the biopsy. But at our institution, the accuracy of grading tumors was very high. And where we ran into difficulties were more in the grade 2 tumors that were at the lower end of the spectrum for Ki-67, so differentiating between a Ki-67 of 2 versus 4. or 2 versus 5. So those were most of the errors actually occurred. So it really is, if we're unable to have a surgical specimen, I do counsel patients that the FNA biopsy gives us some really important information. And in most cases, it's accurate. In some cases, it's not. But it certainly is, it's not a wild guess at all.
Thank you for that. That's really helpful. And we look forward to seeing that paper. Let's ask Dr. Abdonison, if a primary is found to arise from a rare location like a tail gut cyst or epidermis cyst, can it still cause the same disease as a PNET?
So these tumors, they can metastasize, and they, for example, if you're looking at that specific example of a tail gut cyst, which are rare neuroendocrine tumors and can be associated with a rare syndrome called Currarino syndrome, and they can metastasize. They can have carcinoid syndrome with production of serotonin. They rarely do produce any other hormones, but essentially they can. They are similar in the way that they can metastasize. They seem to have the same ability to metastasize as do other neuroendocrine tumors. But in terms of functional tumors, they may or may not be functional. Probably most often non-functional.
Thank you for that. And I wanted to see if anyone else has anything else to add to that. Okay. Let's take a couple questions about biomarkers. And I know this is a big topic. Dr. Kuntz, with consistent elevated multiple high chromogranulin A and clear symptoms, why is it so difficult sometimes to find a recurrent NET?
That's a great question, and certainly something we all face clinically in patients. And I think that, you know, the first comment I'll make is that many of our existing tumor markers are imperfect, and chromogranin A is definitely one of those. And I think that elevated chromogranin A in someone who previously had a resected NET that we thought had, you know, a curative intent surgery and was removed, an elevated chromogranin A does not necessarily indicate recurrence. I think that an elevated chromogranin A can be elevated for other reasons. Certainly it can fluctuate quite a bit in individual patients. And I think the community, and you know, there is an ongoing study looking at this. I think Thor still has it open at Mayo, looking at chromogranin A and trying to validate that a little bit more, and seeing if it really tracks with scans. But it's, I think the pendulum has swung away from using that. I'd like to just also define for our listeners the difference between a tumor marker and a hormone marker. So tumor markers are ones that would not necessarily be linked with symptoms like carcinoid syndrome. So a tumor marker is really more like PSA for prostate cancer or a CEA for colon cancer, that in an ideal world, that marker would increase at time of recurrence or tumor progression and decrease at the time there's tumor response. The hormone markers are something completely different and can be very accurate for individual patients. So for patients with a pancreatic NET that maybe have insulin secretion or vasointestinal polypeptide, we do follow those regularly.
Thank you. Dr. Halfdonisson, since Dr. Kuntz mentioned you, do you have anything else to add to that?
No, I think these are, that was an excellent explanation, so nothing to add to that specifically.
And let's go to you, Dr. Halfdonisson, with this question, if you might speak on the accuracy of the NET test for monitoring and surveillance purposes.
Sure. So NET test, as you may know, is one of the more recent tumor markers, and it's different than most of the others as it relies on sort of genetic signature detected in the blood, usually what's called transcriptomic analysis. So it is a very interesting test. So we know it's definitely outperforms chromogranin pretty much in all studies done. But then, as Dr. Kuntz said, chromogranin is not a good marker, so outperforming chromogranin doesn't necessarily mean that a test is good. And it's just better than what it was compared to. But that said, it seems to be more sensitive than any of the other markers around. And it seems to have like a version of it seems to have a predictive value in terms of patients undergoing PRRT, and that's very, very intriguing to me. We might be able to predict how people do after PRRT. And then recently there was an interesting paper in one of the surgical journals on looking at NET tests following resection. And I've started to use it a little bit in patients who've had complete resection, doing a NET test a few months after the operation. And based on the results, whether it's a high or low or somewhere in between, I might decide on when to do the next scan, be it 6 months or 12 months after that surgery. I will say that is, I don't think it's really validated for that use yet, but it seems like a test that performs well. I think there is a lot more work to be done with a NET test. Ideally, we need to build this into future clinical trials. So where we do trials very rigorously, we should put the test to the same rigorous methodology as we do drugs. And I hope and I think that's going to happen soon.
Thank you for that.
May I jump in?
Go ahead.
Sorry, thank you for saying that. I also think we need to validate that in the constant context of clinical trials, and hopefully by the end of the year we'll have an adjuvant study to look into capecitabine and temozolomide in patients that we believe have high-risk features for recurrence of the resected pancreatic neuroendocrine tumors. And we are incorporating in the follow-up the use of the NET test after the resection to see what we capture at 6 months and then in 3 years or at the time of recurrence. And hopefully that will continue to support and validate the use of the NET test. So thank you for bringing that up.
That is excellent news. I'm very glad.
Yes, that is excellent. And speaking of resection and such, I'm going to transition to some surgery questions, so we make sure we make time for that, since there has been several that came in. Dr. Clark, would you address this question about what is a primary cause of intestinal blockage in NETs patients, and what's the usual treatment for a blockage?
So it's a sort of a complicated question. So it could be from a variety of things. So it could be from the primary tumor. The primary tumors are very small, but they sort of have what we call a desmoplastic reaction, where they sort of pull tissue into the lesion. And so it is easy for the bowel to get sort of folded on itself around a very, very small, like 1 centimeter tumor. More commonly, what we see, though, is obstruction from lymph node metastases, lymph nodes that are actually in the mesentery of a bowel, which is sort of a curtain that the bowel is attached to. And again, these tumors try to grab on to tissue that lay adjacent to them. And so it's very easy, again, for the bowel to be kinked or sort of brought into this lymph node metastasis. And then also it could also be from just peritoneal metastases. So these are cancer cells that are outside of the lymph node, outside of the primary. This would be technically stage 4 disease that can, again, cause the bowel to get kinked off or occluded from tumor growth. And so in these patients, especially for patients that have low-grade disease, surgery is a very good option, if possible, to alleviate obstruction. And I tend to be fairly aggressive about that. In the setting of having high-volume disease that's not necessarily amenable to surgical resection. So, for example, if we have one large lymph node that's really pulled in a lot of bowel and we're worried about leaving somebody with functional short gut, we also sometimes have the option of doing bypass surgery, where we don't actually take out the blockage, but we create a new point of transit for things to move through the bowel. So there are a lot of surgical options. Obviously, these decisions are always made in conjunction with my entire team in a multidisciplinary fashion. So my medical oncologists are also very critical in the decision making in terms of who goes to surgery or not. But I do think that surgery has the best long-term result in terms of trying to relieve those obstructions.
Thank you for that. And another question that came up is, Dr. Clark, is a radical resection recommended of all diseased inguinal lymph nodes under 2 centimeters in size, knowing lymphedema happens and lymph bypass surgery is available?
Okay, so this is in the setting of known lymph node metastasis in an inguinal basin. Yeah, so we do recommend completion lymph node dissections for metastatic neuroendocrine tumor to a lymph node basin. It's a fairly rare setting. We typically will see that in the setting of either rectal primaries or or sometimes from neuroendocrine dermal tumors like Merkel cell carcinomas, et cetera. And the reason we recommend a completion nodal dissection, which means we remove all of the lymph nodes in that particular basin, is because if there is documented gross disease in one lymph node, then there is, 1 centimeter, 2 centimeters in size, then the probability of having microscopic disease in the lymph nodes in that basin is very high. And for that reason, we basically remove all of the lymph nodes, even in the absence of imaging evidence that it's there. And that's often the case. I would say more often than not, we will find additional disease in those lymph nodes. It's a very, I think, nuanced discussion with the patient. Obviously, it's not a risk-free surgery. However, the risk of lymphedema increases with the size of the lymph node and the disease burden within the basin. And so actually sort of waiting to see, if these tumors get bigger or more tumors recur can potentially make kicking surgery down the road a little bit more high risk for that complication. But again, I usually have a discussion with the patient, and then we have what's going to be the best decision for them. But in most cases, actually, lymphedema is quite manageable, and I do a lot of these operations. And clinically relevant lymphedema is really, I think, what everybody worries about, but it's not as prevalent as patients think. So I have them meet with occupational therapists and physical therapists before we get measurements. You get fitted for garments, and there are definitely ways to manipulate the swelling and that ultimately will happen from surgery. But we try to minimize it so that it doesn't change your lifestyle or affect your day-to-day.
Yeah, thank you. It sounds like you take a very proactive and holistic approach. And a follow-up question to that. So regarding preventative removal of abdominal and pelvis lymph nodes that was not done in the initial surgery, what criteria are there to remove it or not, and what side effects might this cause?
This is such a critical point, and it's one of the things we alluded to, the fact that especially in low-grade disease, well-differentiated low-grade disease that is appropriately surgically resected without evidence of metastasis, we can really achieve what would be equivalent of a cure, in that people die from other causes. And so that first operation is really critical. And so I always really try to remind people of that your first operation, if you know that you have a neuroendocrine tumor, should be done by someone who takes care of this disease all the time. But in the setting of lymph nodes left behind, I see this all the time, and I do usually recommend additional surgery for lots of reasons. There's almost always disease left behind at the time that I see patients, whether we capture that on cross-sectional imaging, on CT scan, or on PET dotatate. Especially for small bowel carcinoids, the lymph node drainage from these carcinoid tumors is quite extensive. And it helps us to not only treat their disease surgically, but also prognosticate, and it also has implications for adjuvant therapy. So I do think that if a regional lymph node has not been lymphadenectomy has not been performed, I typically recommend it up front. And more often than not, I find additional disease at the time of surgery.
Thank you for that. And one last surgery question is, what's the latest news for liver transplant for NET patients with localized liver mets?
So this is a big topic of a lot of debate. So there's been some recent changes in the allocation of deceased donor liver transplants. And previously we were very tied to sort of geographic location and availability. And so in some cities, you were more likely to get a liver transplant, and in other cities, you were less likely to get a liver transplant, regardless of how sick you were, based on sort of the pool of available organs in that particular city or area. To sort of try to ameliorate that and make that more even or fair, they've changed the way that we regionalize how organs are distributed. And so what that's done is it has increased availability of organs to patients that are sicker and have higher MELDs. And from the standpoint of neuroendocrine tumor, it is a disadvantage because we don't necessarily get a lot of the bonus points for cirrhosis or a HCC, that would sort of put you at the top of the list. So I think this has really re-energized the conversation around living-related donors for liver transplantation. And so I do think that there are some centers that are still interested in transplanting patients with neuroendocrine tumors that are isolated to the liver. But mostly I think this is going to be in the context moving forward for living-related donors.
Thank you for that. And briefly, I'm going to try to take a couple of treatment-related questions. So, Dr. Coons, this is a big question. What are treatment options existing or upcoming for individuals who do not have somatostatin receptors?
That is a very hot topic right now, and I think one that the NET community is really actively trying to investigate. So there are some agents that can upregulate or increase somatostatin receptors being expressed on the surface of cells. Those are being evaluated in very early phase trials. I'll point to Dr. Suarez, who's actually personally doing some of that work. So that's one. And I think then really thinking of agents outside peptide receptor radiotherapy. So I think we're eager to see if there are other biologic or targeted therapies, or are there, I think immunotherapy we've been talking about for years for NETs, and single agents don't seem to work, but are combination therapies. So I think, yes, in the last 3 years, the peptide receptor radiotherapy has really been the hot news, but we also don't want people without somatostatin receptor expression, or even people who progress on PRRT. We want those patients to feel like, yes, the research community is actively thinking about that.
Thank you. I want to see if anyone else has anything else to add. Okay. Dr. Coons, here's another really important question. This was upvoted as well, so I want to get to it. In treating pancreatic NETs that have metastasized to the liver, et cetera, are therapies such as CAPTEM and PRRT used more than once when disease progresses again?
So that's a question that's sort of broadly an oncology principle. Usually, if somebody progresses on a given therapy, we usually set it aside and generally do not return to it because of concerns that those cancer cells are resistant. So I think I might use as an example PRRT. So I think this is a slightly different setting than your specific question, but for patients who've had the standard 4 doses and then have a long period of disease benefit or duration from that PRRT, we can sometimes consider retreatment and using it, but that's really only because we think patients had benefit the first time around and didn't have resistance to it. So overcoming resistance to certain treatments is also an active area of research broadly in oncology, but to specific agents, and figuring out why those resistance mechanisms develop and how can we overcome them.
Thank you for that. And Dr. Halfdannerson, I'll address this question to you. Is there new treatments for DIPNEC? And please expand a little bit on this.
So not necessarily new treatments. The question is, why do you treat DIPNEC? So a lot of DIPNECs don't have to be treated at all. So these are essentially tiny little clusters of neuroendocrine tumors, and it can occasionally over time evolve into a more aggressive invasive neurotumors, but a lot of times actually it doesn't, even over the course of many, many years. So the reasons to treat DIPNEC are predominantly symptoms, shortness of breath, wheezing, like asthma symptoms, and somatostatin analogs seem to have some activity there. We collaborated with Moffitt and with a center in Israel looking at this, and we found that there is definitely, it seems like somatostatin analogs may work. Other treatments, such as PRRT, everolimus, and others may be considered for really progressive disease, but the first question you need to ask, do you have to treat it?
Thank you so much. And thank you for this first group for all of your time and energy and all your dedication and hard work. And now I'm going to hand it off to Josh, who will moderate the second part of our Q&A.
As we all turn on our various, Dr. Duma, if you could turn on your video as well. Let's see, do we have you here? All right, I thought I saw her on here. Yes, you're there. All right. Well, it's great to see everyone here, and many of us have worked together in many of these settings and these conferences. So it's a pleasure to have all of you here. I'll get right to it as we look towards the second QA panel with Dr. Netting, Dr. Del Rivero, Dr. Hope, and hopefully Dr. Duma when she's able to join us. So there's lots of questions, and I'll start out with Doctors Hope and Netting. I know, Dr. Netting, in your conversation, in your particular talk, you talked about following PRT with SearSpheres and the study that you did as well. And one of the things that of question or concern is for those who had SearSpheres prior to PRT. You kind of mentioned a little bit about the Penn study, but do the two of you want to comment about how you view patients who've had SearSpheres and are looking for PRT?
So I think these patients need to be discussed in a multidisciplinary setting. We know that PRT in general, only about 1% of that total dose goes to the liver, whereas up to 100% of the dose from radioembolization goes to the liver. There's really two different products, and I wouldn't consider resin microspheres and glass microspheres the same product. Typically, an infusion of glass microspheres tends to be about 2 to 3 times more radioactive than resin microspheres. So you really have to look at all of these things in combination. Dr. Sulin's study showed that patients who were heavily pretreated with liver-directed therapy that then underwent PRRT did have a higher complication rate than patients who historically did not have much liver-directed therapy. I don't have a great answer for you. I think it needs to be discussed with all the players who are treating these patients at the same time.
Yeah, I think that's exactly right. The only thing I would add is one thing I think patients oftentimes don't think about is the size and distribution of their tumors, which is really why you do need that multidisciplinary discussion, which is if you have like one big lesion in one area, hit that with radioembolization. If you have diffuse tumors, the impact on the background liver parenchyma is different based on the geometry and the location of your tumors. And so there's no right answer in this discussion. And actually, sometimes we have done Y90 prior to PRT purposefully to debulk localized large tumors so that the PRT will go to the residual. Whereas, so you really need to take into account the geometry, the location, and you really need your IR physician and nuclear medicine physician to talk to each other and think about what's the best for that individual patient, and there's really no right answer.
Thank you for that as well. And the next question coming up is about Y90 liver embolization. Is it superior to bland embolization? Is it worth the potential additional damage? Although I'm not sure there's any potential damage to healthy liver tissue in comparison. So, and I know Dr. Netting, you touched on that a little bit. Do you just want to answer this quickly with just a follow-on?
Sure. So I would say that there has been a lot of discussion recently about RILD, or radiation-induced liver disease, that happens from Y90. It definitely can happen. It's probably more common with a glass microsphere versus a resin microsphere. That being said, it is relatively uncommon. And we tend to use radioembolization more segmentally or lobar. 10 years ago, we used to treat lots of whole livers with Y90. Now we reserve it more for focal or segmental infusions of tumors that may be difficult to access surgically, such as those underneath the diaphragm or in the center of the liver.
Thank you very much. And Dr. Duma, thank you for joining us. I'm glad you were able to get everything in, or at least able to join us and answer some questions here as well. One of the questions that certainly comes up, with all patients, what if your oncologist is not interested in or hearing about integrative medicine? What is your recommendation for how to work with your oncologist who may not be interested in that. Nope, just lost her again. So that's going to be, looks like that's going to be my lot today. But interestingly enough, Dr. Hope, we've had a lot of things recently, and this is on to antioxidants, and we'll see if Dr. Duma comes back in, but doing antioxidants while you're doing PRT or during therapy. And so do you have any recommendations, or what do you tell people about integrative oncology, using antioxidants or other supplements prior to PRT?
Hi, Josh, can you hear me? Sorry.
We can just hear you as well.
Did you want to step in there and answer that, Dr. Duma?
Sorry about the connection. I'm currently in the Midwest to Boston. So I think what is very important is to meet with the pharmacist and go over every medication, and all depends on the treatment the patient is in. Most of the data is extrapolated from other more common tumors, like breast cancer, in which antioxidants are not recommended when you're in chemotherapy. But there's a lot of medications or a lot of complementary medicine that are not controlled at all. And I have lost patients to the side effects of these drugs. For example, cheese or other supplements. So I think having an open conversation with your oncologist is important. If your oncologist doesn't feel comfortable, the pharmacist can be a very good point of contact. And if that pharmacist doesn't feel comfortable, many institutions have a complementary integrative group that we go over the supplements. Because currently, I think in the last few years, we have seen more and more supplements. And many of them are unknown how they will interact with therapy. And I have seen supplements that make the symptoms worse, particularly now, they can make it significantly worse.
Dr. Hope, what do you do with patients who are coming up to you about and asking those types of questions?
Yeah, I think Dr. Duma hit on a lot of the points there. You know, in the end, we don't know most of the interactions here. I mean, I deal primarily obviously with PRT, and we don't know if it helps or hurts any, these how they interact with supplements. I think the symptoms is something that patients themselves, they learn that as they take their supplements, and they can, see how their symptoms change. We have had patients who take supplements and have negative effects from them. Because they take so much of them, but that would be true in any setting and not specific to PRRT. And I think you asked specifically about vitamin D, which is slightly different. I don't think of that in the same setting as a supplement, in the sense of like vitamin D can be potentially an anti-cancer therapeutic, and probably does interact with radiation therapy in some way, although we haven't proven that in any prospective study. So there are things like that are being studied in colon cancer and other cancers that may potentiate a therapy, but I would not start using that now unless we have trial data to support it.
So, Dr. Hope, there's a few questions on imaging specifically, and I'll try to bundle them up here a little bit, but relative merits of copper-64 dotatate versus other dotatate scans as well. Do we always need PET scans? PET scans versus CTs? Often we hear PET scan is the gold standard, and when are the times that when you don't use a DOTA PET scan?
Yeah, so the first one, neither of those questions are particularly easy, but copper versus gallium. So copper is a little more technically challenging because it has a lower amount of decays. The positron that is emitted, there's fewer of them, so you need to scan for longer to get an equal image. You can make them the same by changing your acquisition protocol and optimizing it for your specific scanner. In general, the difference, even if you didn't image for much longer, the diagnostic differences between the two compounds would be very, very limited in terms of the impact on the actual management of the patient, right? If you have a little noisier picture, you're not going to miss the majority of the disease. It might be harder to see small, very sub-centimeter sites disease, which is not really going to change the way a patient's managed. So in general, I think of them as equivalent. We use them both at our institution. We've been doing more copper recently for various reasons, both distribution reasons and reimbursement reasons. The second part of your question about conventional imaging versus DOTA, I generally would not recommend DOTA for routine surveillance of patients over time. I think you really want to see whether or not stuff is anatomically changing in size to see if patients are progressing. Changes in uptake on a dotatate is not indicative of progression in and of itself. It's really either seeing new lesions or the change in size of lesions. And then I think, Dr. Nutting might be able to speak to this, but a lot of people need conventional imaging to plan their therapies, right? A surgeon or an interventional radiologist, you want to know if that lesion's arterially enhancing, you want to see the anatomy of the arteries, et cetera. So there's significant value in conventional imaging, and that should still be the workhorse of the way that we follow patients over time.
I agree with Dr. Hope. I think that we get a lot of anatomic information from contrast-enhanced CTs as well as MRIs. DOTA scans are great because it's easy to see disease, but some of these other scans are helpful to determine increasing size.
Dr. Del Rivera, just going back, I know you're kind of here on symptom management and in your role as an endocrinologist, and it's so good to see you in this flat earth that we have here. So do NETs produce hormones which affect other diseases such as endometriosis, or what other impacts does this have on us?
Thank you so much, Josh, for the question. And as we all discussed earlier, and something that we need to differentiate is between the tumors that produces hormones versus a tumor that do not produce hormones. And in terms of the tumors that produces hormones, whether they are from the small bowel producing serotonin, that's what basically causes a carcinoid syndrome, or because it's the pancreas, neuroendocrine tumors, because the pancreas is a very juicy organ that produces a lot of hormones, produces somatostatin, glucagon, insulin, pancreatic polypeptide. So there is a lot of hormones that is produced by the pancreas. However, based on what the neuroendocrine tumor is that produce a specific hormone, they have specific symptoms that don't necessarily correlate with other diseases within the organ. It has a series of symptoms, like, for example, pancreatic neuroendocrine tumors producing insulin. So we know the symptoms is low blood glucose, but that doesn't mean that it could cause other secondary cancers, or it can cause any endometriosis, like you discussed earlier. Now, in the sense of Cushing's, for example, that's another hormone. Bronchial neuroendocrine tumors, in rare cases, they may produce a hormone called cortisol. It's a hormone that may stimulate the production of cortisol, and that excess of cortisol has a series of symptoms. It can cause obesity, the red face, what we call the buffalo hump. That's kind of one of the characteristics of the excess of cortisol. It can affect also the bones, making your bone weak. It can also cause hypertension. So those are kind of like the effects of the hormones in a specific organ of function, but doesn't necessarily cause any other diseases that are not related to the neuroendocrine tumor. I don't know if that answers the question.
It does greatly, and I kind of a follow-up to that in a sense here is we're taking SSAs in the earlier session we talked about somatostatin analogs all the time, and much like when we're under any other therapy, are there any diet or treatments or other supplements that might help the cramping and bloating or the gurgling that comes with the GI tract after taking a somatostatin analog? And I'll open that up a little bit. I'll have you talk about SSAs to start out with, but certainly other things, thinking about diets while going through other therapies as well. Okay, great.
Well, thank you so much. That's also a good question. But first, I think the first thing that I would like to describe is what SSAs are doing, somatostatin and lanreotide. So one of the things that these medications are doing is inhibit the hormone in the pancreas. So every time that we think about somatostatin agonist, it's an inhibitory type of drug that inhibit the function of the hormone in the pancreas. That's the reason why whenever we have a pancreas neuroendocrine tumor, so we have a functional neuroendocrine tumors, somatostatin agonist has two functions. One is to control the excess of hormones or the symptoms related to the excess of hormones. And number two, it has an anti-tumor effect to slow down the growth of the tumor. Now, in the sense of having these inhibitory functions or inhibit these hormones in the pancreas, one thing that they're doing is that also inhibit the function of some pancreatic enzymes. So sometimes there is some difficulty by breaking down fats, breaking down sugars, breaking down also some starches, and that's basically what it causes symptoms of bloating and so forth. Now, usually it occurs a few days after the implementation of the injection of the SSA, and over time it tends to get better. But in the time that these symptoms are, these medications are causing these symptoms, sometimes that could help, for example, is to minimize the amount of fat and the amount of sugar as well, because as we say, this medication can sometimes slow down the breakdown of the fats and sugars, and we're able to minimize the amount of these sugars or fats that we're ingesting, maybe having small meals throughout the day. Sometimes that can definitely help to some of the symptoms. Now, there are some other broccoli, for example, this cruciferous kind of like vegetable, so that can also cause bloating, maybe minimizing that as well can help in those situations. But yes.
So Dr. Hope, I'm going to throw this at you for a second. I often have patients who have platelets that drop in and either think or want to know if there's some type of dietary things that they can do to help up their platelets, or how do you tell patients to manage their diet, or do you in concerns with their blood work? Because I know this comes up a lot in patient land.
Yeah, I don't know how I got into being a dietary representative on this show here, but in general, the way I think about it is when we give, in the setting of PRRT, when you have low platelets, red blood cells, and white blood cells, there's a cause for that. It's the radiation injury to the bone marrow. And it's not exactly something that's going to be fixed by a dietary change or a supplement. So I obviously, I like to stay in my lane, and my lane is a nuclear medicine physician. So we have a very strong nutrition service that we send patients to have these discussions. But in general, I don't make strong recommendations. Really, it's a tincture of time, right? PRT, most of the low counts is due to the radiation effect, and they'll recover over a period of time. And really, it's waiting for your marrow to recover from the transient injury from the radiation.
Yeah.
I'm going to stick on the somatostatin analog world here, although I just lost this question, but I'll see if I can find it. When is the appropriate time to have imaging vis-a-vis and therapy vis-a-vis your somatostatin analog injection?
That is a great question. I think that's changing. Our belief in that is changing over time. So I'd say 5 years ago, we were all doing it days before their next injection, right? We were very strict about it. And then there was a paper that came out 2 years ago that showed with lanreotide, there's very little impact on the uptake seen on somatostatin receptor PET. And then there was a recent article, actually a year ago now, with sandostatin that showed a similar lack of impact on your SUVs, the uptake on the PET imaging. And actually, I think I'm becoming much less stringent on that criteria. So with lanreotide, we still schedule our treatments because that you have a little more control over before the next dose. But in terms of imaging with lanreotide, I'm hearing less. I don't think it makes really any difference. With sandostatin, I've had a patient where they were on very 120 milligrams of sando, and that did actually impact. You could clearly see it sort of attenuating the uptake on the dotatate PET. But in general, in patients with normal doses, I don't think it makes any difference in terms of timing. So but that's changing. My mind on that's changing over time.
Yeah, no, certainly I think it is an evolving science because we didn't know a lot in the beginning, and we were just certainly taking guesses here. And it's really great that we're doing this with more information now. Dr. Netting, do you think there'll be a time when ablation for small p-nets will be a common procedure?
I would assume that's discussing liver-directed therapy.
Yeah.
And as far as small goes, Dr. Thor had mentioned earlier, is it something that you need to treat? So in general, we tend to treat tumors that are 3 centimeters in size and 3 or less in number with needle-based therapies, such as ablation. In my practice, I don't see very many 1 centimeter tumors that are isolated. It tends to be more of a diffuse disease spread throughout the liver, and that tends to be treated with regional liver therapy.
Thanks very much for that answer. I don't know that either Dr. Hope or Dr. Del Rivero, you have anything to add to that? Back to you, Dr. Hope. This is kind of the PRT questions in a couple different ways. One, in NETTER-1, did you see any complete responders, or have you seen complete responders as part of those who are undergoing Lutathera?
We have not seen any complete responders in the patients we treated with Lutathera to date. Now, I will say the definition of a CR in a setting of NETTER-1 versus clinical practice is different. What I mean by that is now that we have dotatate PET compared to conventional imaging, it's much, much harder to be a CR. And I think my take-home point would be PRT does not cure patients, right? And actually no therapy we do cures. And I'm not aware of, and maybe Josh, you're aware of one ever, but I'm not aware of any patient ever who has had, quote, a cure from PRT. So CR just means we knock that disease down so much, and it's hard to see on conventional imaging, but it's still there. And I think there's maybe a misunderstanding of what CR means maybe in the patient community, that means that they have no disease, and that is not true.
I'm going to follow that up, and I'm going to get back to your point there in a second. But the other follow-up to that is PRT effective when you have large tumors greater than 5 centimeters? One of the questions is this an effective therapy when you do have large tumors? And I would assume also large liver load of tumors as well.
That's a great question. So, so the larger your tumor is, the less benefit there is from therapy. And that's probably true across all therapies, right? Bulkier tumor, higher volume tumor does less well with any type of therapy just because it's a worse prognostic finding for a patient. PRT in the NET, they retrospectively looked at patients in NETTER-1 and showed that the patients with larger tumors did less well, but there was still a benefit over Sandostatin, right? You still had the clinical benefit, so it's not that you shouldn't treat patients with tumors like that. And we have had patients clearly who've clinically benefited and had prolonged progression, radiograph progression-free survival from it. So I think it still should be used. Now, I think maybe what this question might be trying to get to is when should you use PRT? And it's a volume of disease, and we don't really know the answer to that. So I think there's clearly there's too low volume disease to treat, right? I don't know how you define that. And then, you don't want to wait till you get too big of a volume disease because the benefit, you're spreading out your dose over more tumor and there's less of benefit. So there's this sweet spot. We haven't defined that sweet spot, but I believe that there's some sweet spot that exists where you want to treat patients with PRRT that has sort of moderate volume disease where it's going to be most effective, right? You want to use that drug in the window where it's most effective.
So the last question is actually to me, but I'm going to turn it around and make it to all of you, just because I can. So we've just gone through a conference where we've had 10 wonderful doctors from really around the country, literally everywhere around the country. We're not all able to afford to go see you all. The question really was, are there any sponsorship or grants to have us see you wherever you are? But how are you dealing with seeing patients from around the country? Obviously, Dr. Netting, to actually do any liver-directed therapy, you actually have to have them physically in Denver. Hard to do that remotely yet. We'll get to that technology soon, I hope. How are you seeing patients around the country? What do you do for people who want to either have a second opinion with you and or deal with this kind of travel in this new flat Earth? And I'll let you each talk to that real quickly, and then I'm going to bring it back to the studio. So I'll start with you, Dr. Del Rivero, and how you're seeing patients with NIH.
Thank you so much, Josh. I appreciate the question. So As we know, NIH is a research institution, and every patient that we see at the NIH has to be enrolled under a specific protocol, whether it's a treatment protocol or whether it's a natural history study. At the NIH, we have a natural history study for neuroendocrine tumors. I am the PI of that study, and it's a longitudinal study, meaning that I'm allowed to follow patients long term. On that study, we have two cohorts of patients. We have a field cohort and we have a clinical cohort. Clinical cohort are for patients that are able to come to the NIH. Field cohort are patients that could be from anywhere all over the world. And the idea is that we collect all the information, we collect all the clinical information, collect tumor, collect any radiology. And what we do is that we present that on our tumor board. We have a tumor board every Thursday. And then we have our own clinical group, which will help make the decisions about the possible recommendations for the patients. We then give the recommendations back to the patient. And of course, we always say we haven't seen you in person, but this is based on the scans, based on the labs, based on what we review. This is our recommendations. And we're always happy to talk to any of the providers outside of the NIH. So that's an easy way for patients. So because it's under a research study, is without cost, but at the same time, we don't necessarily see the patients in person. So that's one thing. It's a research study, so the patient needs to be eligible for this study as well in order for us to evaluate any neuroendocrine tumor.
So Dr. Netting, are you seeing people remotely before they come to Denver, or how are you doing your work?
Yeah, thanks, Josh. I think one thing that COVID has done is really forced the evolution of telemedicine. And so I'll see patients remotely. We can also share images through different platforms such as nucleus.io. And we could come up with a treatment plan for these patients before they ever come see us in person. So it's very common for us to discuss them in a multidisciplinary fashion, get insurance authorization so that when they do come to Denver, we're ready to treat them.
And Dr. Hope, I know you certainly see patients remotely, whether they're inside of your Northern California area or from around the country. How does that work?
Like this? No.
It looks pretty much like this.
No, I mean, this is what I love about the neuroendocrine tumor community from the patient side, is that patients really do, and they've been doing this well before COVID. They see physicians, get second opinions. We all share each other's patients, and COVID just made it easier, right? And you do it over Zoom now, and that's sort of acceptable, right? The first time, it used to be that the first time you saw a patient was always in person. And that was sort of like the rule of thumb. And that's actually just gone out the window, which is really nice, which makes it much easier to see patients, and patients love getting second opinions, and they should, because it helps you feel more confident in the decision that you end up making. And I think that's really important. So COVID's done a really great job sort of breaking down these barriers that have historically been in medicine about how you had to see patients in person to really give access to patients to get second opinions around the country.
So I want to thank you really all for your time. It's such a great pleasure to see you here, even though we're all flat, but we're used to seeing each other this way now, and hopefully we see each other in person soon. I want to thank everyone for attending today. And I know we've had probably 75 questions, and we probably made it through 45 or 50 questions in this hour and 5 minutes. So sorry if we couldn't get to all of yours, but LACNETS, as well as many of the organizations around the country, run webinars almost every week now, if not weekly. So we're sure you can get your questions answered somewhere. And with that, I'm going to say goodbye and turn it back over to our producer at the studio.
It's been such an incredible day. We've heard from 9 incredible speakers, 2 NET patients, and 1 caregiver. We've learned so much and been inspired. So I'd love to hear from each of you any final thoughts you'd like to share with the NET community. Specifically, what does a theme, Connected in Hope, Facing NET Together, mean to you? Dr. Hendefar, let's start with you.
Thank you. This is a very important theme, is that, the providers and the patients, we're all here today together. This is probably the most anticipated conference of the year. And it just shows how important that link is between the patient and the provider, and how together we can overcome many things.
I would say that what the theme means to me is really exemplified by today, in the sense that we are in this together, whether it's patients or care providers. And I would say, especially with everything that has happened recently with coronavirus and a lot of the other things in the United States, I would say really think about what you can do for others around you, not only yourself, but for others. And I think that will go really far in terms of what we're able to do to advance progress for neuroendocrine tumors and ultimately be able to beat neuroendocrine tumors for everyone.
So I think the reason that this year's theme resonates so much with me is after one of the most isolating and challenging years any of us have faced, it's never been more clear that we really do need each other. Connecting with people who really understand the NET diagnosis, from your physicians to your support groups to family members, can be so transformative for so many patients. From the diagnosis and treatment planning and symptom management, and most importantly, this last year, support and connection, we face NET together. No one should ever feel alone with a cancer diagnosis, and LACNETS is doing their best to make sure that never does happen.
I feel very deeply the same as my co-moderators. With hope, no one walks alone, but through hope, the many walk together. And we are a tribe. We will walk this path with hope in our hearts together.
Thank you, Dr. Henifar, Dr. Lee, Mary, and Beth, for taking the time to share with us your insights and wisdom. I just wanted to add some closing thoughts about why we chose this theme, Connected in Hope, Facing NET Together. We hope that today you'll come away with a sense of hope, knowing that no matter who you are, how you identify, or where you are not alone. Connection is powerful. Know that there are many patients, caregivers, and advocates who truly understand and get what you're going through. There are also many experts, researchers, and other supporters fighting on your behalf. Today, we had the opportunity to hear from some in the Army who are fighting with and for you. They are also hoping for you. When my husband was first diagnosed with NET, my dear friends and family said to me throughout that first crazy year or two, "It's okay if you don't feel hopeful. We will hope for you." So know that you're part of a community that is connected by hope. And now back to you, Lindsay.
Thanks, Lisa. I couldn't agree more. Before we say goodbye, I'd like to again thank Rich at TVP Live. A special thank you to all the presenters, patients, and caregivers who participated today. Thank you to our presenting sponsors, Ipsen and AAA. Thank you to our silver sponsors, Novartis and Tercera. And thank you to our bronze sponsor, Intrinsic Bioscience. As a reminder, our conference is being fully recorded and will be posted on the LACNETS YouTube channel within the next few days. You can find the bit.ly link to our YouTube channel below. Thank you to everyone who tuned in and participated today. Please remember, we are all connected in hope and facing NET together. We are stronger together. We will see you soon. Goodbye.